All right. Hello, everyone. My name is Samhar Alouch. I'm a fifth year medical student, and today, alongside my colleague Abdul Razzak, we are going to do the whole GIT 113 OSPE review. Everything will be mentioned here will be either black or red or other colors. The red things are the high yield things for the OSPE. The black things are important for like SAQ or like general information or even for the MCQ. So first we have like general intro for the digestive system. So the digestive system consists of mouth, pharynx, esophagus, stomach, and so on, till the anal canal. The extra structures like liver, pancreas secrete enzymes and other stuff that help in digestion, but food itself doesn't go through them. So as you all know, we have three embryological structures that forms the GI system. First, we have foregut, then midgut, and finally hindgut. The whole GI system is made from these things, okay? Except like the upper parts. So as I said, we start from the mouth and then till the esophagus. From the mouth till the proximal part of esophagus, it's made through other things, and they are not important. From distal esophagus to the stomach and so on, we start with the foregut, then midgut, then hindgut, and finally the last part of the anal canal is not made by these things. Okay, so first the foregut makes all the upper parts, okay, of the GI, not the one that I mentioned, the upper part of the like middle GI tract. So first we start with the distal esophagus, then the stomach, then the proximal duodenum. Other structures exist here also made by the foregut, such as liver, gallbladder, and pancreas. Everything made by the foregut is supplied by the celiac trunk. Then we have the midgut, and it starts from the second part of the duodenum till the like duodenum, ileum, then the colon, till the proximal two-thirds of the transverse colon. That's made by the midgut. Plus we have the appendix. Blood supply is by the superior mesenteric artery. Then we have the hindgut, which is from the distal like third of the transverse colon till the upper part of the rectum. And they are supplied by the inferior mesenteric artery. So now for the histology of the digestive system, all the organs of the digestive system are made by four layers. First layer is mucosa. Mucosa is the most superficial layer if we consider the lumen is the center. So this is the lumen, it's the center. The most superficial to it is the mucosa, okay? Mucosa has the epithelium, lamina propria, and muscularis mucosa. Okay, muscularis mucosa is a weak muscular layer. It's not a true muscular layer. It's just like some muscles. Okay, so that's the first part, mucosa, epithelium, lamina propria, and muscularis mucosa. Then we have the submucosa. Sub means it's under, so the part under the mucosa, and it has like connective tissues, blood vessels, and the glands. So the glands are in the submucosa, not in the mucosa. There are some exceptions, but for the main point, it's in the submucosa. After that, we have muscularis externa, which is a big muscular layer, okay? And it's very important for like moving the food throughout the GI tract. So the real muscular layer are in the muscularis externa. And finally, we have serosa or adventitia, which is like just connective tissue and some blood vessels outside. So glands are usually in submucosa. However, only in stomach, it's in mucosa. But that's because in the stomach, we need to digest very fast. So if the glands are in the submucosa and like the secretions are being secreted, this will take time to reach the mucosa, then to the lumen. In the stomach, we need to do everything very fast. So it is in the mucosa, so it reaches the lumen quickly. Then, as I said, we have muscularis externa, which is the real muscular layer, okay? And it's the outer part, okay? Because there is a muscular layer, which is inside, but no, we are talking about a real muscular layer, which is outside. That's why it's named muscularis externa. Let's assume this is the muscularis externa. The inner part, this one, is circular. So it is inner circular part. And then we have an outer part, which is longitudinal. Longitudinal means it goes like this, okay? Circular means it goes like a circle. So if you get my point, if we have a pipe or like a tube and we cut it like this and we look from above, it will look longitudinal. So circular layer in histology sections, it will look longitudinal. On the other hand, longitudinal stuff, if we cut it like this, it will appear circular. My point is, if you have a circle and you cut it like this and you looked above, since the cut moved with the circle, everything will look like longitudinal. So circular in histology will appear longitudinal. However, the longitudinal stuff, like a pipe, if you cut it like this, it will appear circular. Okay? I hope it's clear. If you couldn't identify this in histology. Just if they ask which layer is this, inner circular or outer longitudinal, just if it's inner, like close to the lumen, that's inner circular all the time. If it's outer, then it's outer longitudinal. Okay? And last part is adventitia or serosa, which is like have some blood vessels and fibers. Now we will start with the real thing. Okay, first we will start with the oral cavity. So the oral cavity is the first part of the GI tract where food enter. Okay, it has the tongue, it has teeth, palate, and so on. I hope you memorize most of these things. So heart, palate, oral cavity, tongue, the mandible bone. I hope you memorized all of this by now, the soft palate and these things. These are the parts of the oral cavity. If someone opened their mouth like this, you will see the teeth, you will see the hard palate, and here there's also the like hard and soft palate. And we have the tongue, the anterior portion of the tongue, and finally we have uvula. So oral cavity is the beginning of the GI tract. It contains the anterior 2/3 of the tongue. So tongue is made of 3 parts: anterior 2/3, posterior 1/3, and the base. And anterior 2/3 is in the oral cavity. Okay, so oral cavity has anterior 2/3 of the tongue. It also had the hard and soft palates, and it has something called oral vestibule. Vestibule means a small entrance to a place. Okay, so let's assume we have a big door and a small door. The small door is the vestibule. So we have oral vestibule. This, if we open the mouth itself, here it's the like actual door, the big opening, okay? But here it's a small opening, like here. That's the oral vestibule. So the oral cavity has oral cavity proper, which is the actual entering to the like GI tract. And we have oral vestibule, which is a small entrance into the GI tract. So I hope you know what's oral vestibule because it might be asked. Also here we have a projection. It is the papilla of the parotid gland. There is a salivary gland here called parotid gland, and it has a projection here called the papilla of the parotid gland. Then in the floor of the mouth, and the floor of the mouth has 3 important structures. First one is frenulum. Frenulum is this X structure. It is a line or a fibrous tissue that connects the tongue to the floor of the mouth. Then we have sublingual cornicle. It's the opening of the submandibular gland. So we have 3 salivary glands. I will explain that later on. The parotid, okay, the one that has the papilla. And then we have submandibular and sublingual, okay? And we have sublingual cornicle, which is like the opening of the submandibular, okay? Not sublingual, although the name is sublingual. It's the opening of the submandibular gland, okay? And then we have sublingual folds here, and here we have the sublingual fold, which is the sublingual gland. The tongue is divided to 3 parts: anterior 2/3, posterior 1/3, actually it's here, posterior 1/3, and the base of the tongue, okay? Now, what are the important structures in the tongue itself? First, we have an inverted V, okay? As you can see here, there is a V that's inverted, okay? This is called sulcus terminalis. So the first important structure in the tongue is sulcus terminalis. It's an inverted V. It's divide the anterior 2/3 with the posterior 1/3. Then we have foramina cecum. It's a depression in the V. So as you can see here, we have a V. The depression in the V, like the angle, that's foramina cecum. It's a depression in the sulcus terminalis. It's important in the embryology of the tongue. Then we have circumvallate papillae. So we have 4 types of papillae that secrete and help in taste sensation and stuff. One of them is circumvallate papillae, which is anterior to the V. So as you can see here, we have some circles anterior to the V, and these are circumvallate papillae. And then at the posterior 1/3, we have these big tonsils called lingual tonsils. So as you can see here, we have circumvallate papillae. Here we have lingual tonsils. At the lateral of the mouth, we have palatine tonsils. So we'll talk about them later on. Here, as you can see, this is from behind the tongue. So we have the inverted V, which is sulcus terminalis. We have the foramina cecum. We have the circumvallate papillae, and like now the tongue, as I said, is divided to anterior 2/3, posterior 1/3, and the base of the tongue, okay? Each one of them has a specific nerve supply, okay? So tongue has 2 features. First, if you touched your tongue like this, you won't feel a taste, but you will feel the touch, okay? That's the normal sensation of the tongue. And normal sensation in the anterior 2/3 is supplied by cranial nerve number 5 called trigeminal nerve. Okay. Then we have other type of sensation, which is a special sensation called taste. So if you ate something, you will taste it. And that's supplied by another nerve called facial nerve. Okay. So the anterior 2/3 has two sensations, normal sensation and taste sensation. Normal sensation is by cranial nerve number 5. Taste sensation is by cranial nerve number 7. Okay? If you want a mnemonic to memorize why facial is for the taste, once you taste something like bad or sour, your facial expression will change. That's why facial nerve is the one responsible for the taste. Okay, now let's talk about the posterior 1/3. The posterior 1/3 also have normal sensation and taste sensation. Both of them are by the glossopharyngeal nerve or cranial nerve number 9. Finally, we have the base of the tongue, and also it has normal sensation and taste sensation, but both of them are supplied by cranial nerve number 10, which is the vagus nerve. So for the last time, in the base, both of them are by cranial nerve number 10. In the posterior 1/3, both of them are by cranial nerve number 9. In the anterior 2/3, the normal sensation is by cranial nerve number 5. The taste sensation is by cranial nerve number 7, which is the facial nerve. Why is that? Because when you taste something sour or like bad, your facial expression will change. Okay? Now let's talk about the muscles of the tongue. As I said, the tongue itself is a bag of muscles. However, there are also some muscles that comes from outside and attached to the tongue. So we have two types of muscles in the tongue. We have the intrinsic muscle of the tongue. Intrinsic mean inside. So these are the muscles that makes the tongue itself. And we have the extrinsic muscles. Muscles comes from outside and attached to the tongue. How do we name the extrinsic muscles? If we will name a muscle that comes from outside and attached to the tongue, the name has two parts. The first part is the name of the origin, the place that it comes from. And the second part is the name of the tongue itself, which is glossus. Okay, so the first muscle we have is hyoglossus. Okay, and hyoglossus is from the hyoid bone to the tongue. Okay, you can see it here. Okay, this is the hyoglossus. This is the hyoid bone, and this is the tongue. It originated from the hyoid bone to the tongue. So that's hyoglossus. Then we have genoglossus. And genoglossus is from, here we have a bone called mandible. It has a genoid tubercle. A part of it is called genoid tubercle. And the muscle originates from it. So genoglossus. Okay. Then we have the styloglossus, which is from the styloid bone to the tongue. And finally, we have palatoglossus. It's not appearing here, but it's from the palate to the tongue. Okay. It's from above. As you can see here, all of these muscles are under the tongue. Okay, the genoglossus, the hyoglossus, and even this one, the styloglossus, they all come from under the tongue, except one, the palatoglossus. It comes from the palate to the tongue. So all the muscles that comes from under the tongue or the tongue itself, they are supplied by a nerve called hypoglossal nerve, cranial nerve number 12. Okay, from the name hypoglossal, under the tongue. Okay, so all the muscles that originate under the tongue or from the tongue itself, supplied by hypoglossal nerve or cranial nerve number 12, except palatoglossal, because palatoglossal originates from above the tongue, so hypoglossal nerve can't reach it. So palatoglossal muscle is the only muscle that is not supplied by the hypoglossal nerve. Now let's talk about the intrinsic muscles of the tongue. We have a longitudinal muscle, superior, here superior longitudinal, and here inferior longitudinal. Then we have a mixture of vertical and the transverse muscles, like this. And these are the four muscles of the tongue itself. Superior longitudinal, inferior longitudinal, vertical, and transverse muscles. All of them are supplied by hypoglossal nerve. So, what's the function of the hypoglossal nerve? All of these muscles, main action is to push the tongue out. So imagine here we have the right side, the left side and the right side. We push the tongue from both sides, okay? Now imagine that the hypoglossal nerve that's on the right is damaged. When we push the tongue, we will push it like this, okay? Like this left side is going all out, but the right side is not going. So the tongue will deviate to the side of the damage. So here is the tongue, and here are the muscles, and here is the hypoglossal nerve from both sides. This, let's say, the left side, and this the right side. If I damage the right side, I can't push, so the tongue will be deviated like this. And so, if we have damage on the hypoglossal nerve, the tongue will deviate to the side of the damage. So, damage to the right side of the hypoglossal nerve will push the tongue to the right side. Okay, please memorize this. I tried to explain it so you understand why it happened, but even if you didn't catch it, it's fine. Damage to the left hypoglossal nerve, the tongue will deviate to the left. Damage to the right side of the hypoglossal, the tongue will deviate to the right. So the damage side is the deviation side. Now lymph nodes. All just take it as a like a rule. Everything in the head and neck area will drain in the end to the cervical lymph nodes. Okay, so here we have the tongue, and the tongue, what is under it? The mandible and mental. So it will drain into submandibular and submental lymph node. Okay, and after that, the fluid that is drained to the submental and submandibular, because it's in the head and neck area, it will drain to the cervical lymph node. So anything in the head and neck area, cervical lymph nodes. Anything in the mediastinal area, to the mediastinal lymph node. All right, now we will talk about the tongue papillae. So what is a papillae? Papillae is a projection. So imagine we have the tongue epithelium like this. That's not papillae. Papillae is like this. We have the tongue and then we have a projection, then projection. That's papillae. What is papillae made of? It's made of a core and a surrounding. The core is made of fibromuscular tissue, like connective tissue and so on. The outer part is made of epithelium. The epithelium of the tongue is stratified squamous epithelium, okay? So the papillae is made of fibromuscular core surrounded by stratified squamous epithelium. These projections is not on all of the tongue. It's in the anterior two-third only, okay? So the tongue papillae or lingual papillae are on the anterior two-third of the tongue. And we have 4 types: filiform, fungiform, circumvallate, and follate papillae, okay? Now let me explain the location. As we said, circumvallate are anterior to the sulcus terminalis. It's these things. These are circumvallate. For fungiform and filiform, it's throughout the whole tongue. And follate is not present in human, but in animals, it's on the lateral side of the tongue. So we have 4 tongue papillae. Now let's talk about histology of each one of them. First, we have the filiform papillae. From the name, it's fili. Fili is like filling. It's like the filling of the whole tongue. It's filling the whole tongue. That's why it's filiform papillae, because it's filling the whole surface of the tongue, and that's why it's the most numerous. What's the function of it? It's increased friction to help digestion. Okay, so it's like cause friction with the food itself to help us with digestion, and it protect the tongue itself. It doesn't have taste buds, so it doesn't help with the taste sensation. Okay, so filiform, it fills the whole tongue and it helps with friction and protection. It doesn't have taste buds. Okay, where is it? On the entire dorsal surface. And what's the histology of it? Anything that causes friction needs keratin, because keratin is thick, okay? It will help with the friction. So the only one that has keratin is the filiform. It's thin papillae with keratinized tip. Okay, once you see keratinized tip, that's filiform papillae. It just look like very thin papillae like this, and it has a keratin tip. Okay, if they ask you what epithelium is this, stratified squamous epithelium. Then we have the fungiform papillae. Fungiform, it also fills the entire surface, but it has less number than filiform. Okay, from the name, fungi means mushroom. So fungiform is mushroom-shaped papillae. So it looks like a mushroom. As you can see here, it looks like a mushroom. Location, dorsal surface. The function is taste. Okay, all of them are for taste except filiform. Okay, so the fungiform is mushroom-shaped and it's important for taste. Now, how do you see it in histology? It's like a mushroom. Okay. And inside the mushroom, there are multiple roots and projections. Yani if you see a mushroom like this with only one, that's usually not fungiform. We will talk about it later. But if it has multiple projections, that's fungiform papillae. So it's mushroom shaped with multiple projection inside it. Okay? Under it, there is serous gland. Then we have the circumvallate papillae. Circumvallate means qubba. If you know in Arabic, it's like a qubba, okay? You know the part of the, let's say, mosque that's like this. Yeah, this is what circumvallate means. Okay, so how will it look? Dome-shaped papillae. Okay, this like dome shape. Okay, so circumvallate papillae are dome-shaped papillae. Where are they? As I said, it's in front of the sulcus terminalis, and they are arranged in a V shape. What's the function? All of them are for taste except filiform papillae. Histology, dome-shaped with few projections. Okay, so if you see a dome or like a mushroom, because it's not that easy to differentiate between a dome and a mushroom in all pictures. Like I may say oh wait, maybe this is a mushroom. Then I look inside it, then it has only two projections. That's not fungiform, that's circumvallate. Okay, so fungiform is a mushroom with multiple projections. Circumvallate is a dome shaped with like one or two projections. Okay, that's how do you differentiate. And in the submucosa under it, there is serous gland. Finally, we have the fillate papillae. They look like parallel ridges, like this. As you can see, filiform is very thin with keratin tip. Fungiform is mushroom. Circumvallate is like a dome shape. And here it is ridges, okay? Just like ridges next to each other with like, if you have a ridge, you will have a crypt here. Crypt means, ridge is going up, crypt is going down. So we will have also like structures going down. Anyway, where is it? It's not in a human, it's in animals. Where is it exactly? On the lateral side of the tongue. What's the function? Taste. Where are the taste bud? On the lateral side with a spindle-shaped structure, okay? In all the others, the taste buds are like here, also in the lateral side and like everywhere. However, they look diffused. You can't really identify them easily. However, in fillate, they look like a spindle shape. It's like a really big cell, as you can see here. That's the taste bud. Okay, now we will go to like important glands. The submucosa in all the GI tract, except the stomach, it has glands, okay? These glands can be like salivary, mucus, whatever, okay? But most of them secrete either serous secretion or mucus secretion. In histology, serous secretion is dark, okay? It looks like dark pink or purple, okay? Dark pink or purple. The mucus secretion is light. It looks like light pink. So in one of the questions here, it didn't mark circumvallate papillae. It marked here. And it was like, this is a serous gland or a mucus gland. Okay? It is a serous gland. Why? Because it is dark. I know you may say this is not as dark as this. No, but that's considered dark. When I will show you what is mucus glands, you will appreciate how much light it is. It's like the keratin. It's very, very light. So that's why I said here, under these papillae, there is serous glands, okay? Because it was a question. Now let's talk about like the real important gland. So the salivary glands are glands that secrete saliva, and they are important in like digestion, okay? This was a question. It will show you one salivary gland and what's the function. Secreting saliva and amylase to help in digestion. I hope you memorize this like your name, okay? Now we have three salivary glands. First is the parotid gland. It's the largest and it's here in the side of the jaw. Okay? It's the parotid gland. Then we have the submandibular. From the name, it's under the mandible. And finally, we have the sublingual, which is under the tongue. The parotid gland is only serous. Okay? So you will see it as dark pink or purple. Okay? The submandibular is mixed. And sublingual is mucus, so you will see it as light pink. Okay, so parotid is the largest and it is very dark because it is serous only. Submandibular is mixed and sublingual is light pink. Okay, all of them are surrounded by fibrous capsule. Keep this in mind. There is an exception, but just keep this in mind. All of them are surrounded by a fibrous capsule. So this is the gland and it's surrounded by a capsule. This capsule is made of fibrous tissue. It will give a septum. And this septum, let's say it goes throughout the whole gland, dividing the gland into two lobes. And then it will give another septum, dividing it into more lobules, okay? So the salivary gland are surrounded by a fibrous capsule. The capsule will give a septum that divides the gland into like different parts. All of these glands, I hope you guys know this by now because I think it was in foundation. Any gland is made of acini and a duct. Acini is the part that actually give the secretion, like give the saliva itself. The duct is the part that transmit it to like where it should be, okay? So if the acini is serous, it's going to be dark pink or purple. If it's mucus, it's going to be light pink. The duct is like an open tube with epithelium and cells around it. So here we have mixed. This is the submandibular because it's mixed. As you can see here, it's dark pink, which is serous. Here it's light pink, which is mucus. Since it's mixed, that's the submandibular gland. Okay? Now let's start talking about each gland on its own. Parotid gland, as we said, it's in the upper part of the jaw, lateral side, and it's the largest. And it gives serous secretion only. And since it's serous secretion, it's going to be dark pink or purple. Okay, it is surrounded by fibrous capsule and it has serous acini duct and something called myeloepithelial cells. Now, all of them has myeloepithelial cells, but specifically parotid gland has a lot of myeloepithelial cells. From the name, myelo means muscles. Why do we need this? This is the acini, okay? It will contract and give the secretion, but it won't, like, because it's very big, it needs more force. So there are myeloepithelial cells, which are muscle cells that also help in the contraction of the acini to push everything out. Imagine toothpaste and it's at the end of the month and you are trying to push everything out of it. So you are really pushing very hard, okay? So the myeloepithelial cells will do that. It will push really hard on the acini to help it secrete everything. It is in the others, but it's mainly in the parotid gland because it's very big. So the parotid gland has a fibrous capsule and it has serous acini, which gives serous secretion, which is dark pink or purple. It has a duct and it has myeloepithelial cells, which is muscle fibers that help acini secreting the secretion. Why it's most predominant in the parotid gland? Because it's the largest. Now, it may give you a picture and asking what's the differentiating feature of parotid gland, that it's fully serous. It's only made of serous acini, which is dark pink or purple. As you can see here, that's the dark pink acini. And this picture here to show the fibrous capsule, this part is like this whole thing is the gland, and here is the fibrous capsule surrounding it. Now we will go to the submandibular gland. What do we say about submandibular gland? It is mixed. Okay, so it has serous and it has mucus. So mandibular gland is under the mandible of the jaw. And as we said previously, it opens into the sublingual chronicle. I'm really emphasizing on this because it was a question. It will point out at the sublingual chronicle. If you remember the thing in the floor of the mouth, like here, and it will ask you what gland will open into this, and you will say, oh, sublingual gland. No, it's not sublingual. It is submandibular. Okay, the name is lingual because it's just under the gland. However, the submandibular gland is the gland that open into the sublingual chronicle. It's surrounded by fibrous capsule made of both serous and mucus acini and something called serous demilune. Okay, so first let's start with the serous acini. Most of the gland is made of serous acini. So although submandibular gland is made of mixed serous and mucus acini, it is mostly made of serous. And that was a question. What's the most common like acini in the submandibular? It is serous. So it's mostly serous. And since it's serous, it's full of dark pink or like purple structures. And it also has mucus acini, which is less, and it's light pink. Now we also have something called serous demilune. Loon means الهلال, okay? You know الهلال, yeah, that's loon. Okay, so serous demilune, it's a serous acini that looks like demilunes and it surrounds the mucus acini. So as you can see here, we have a mucus acini and it's surrounded by like lunar structure, which is the serous demilunes. So once you see mucus acini surrounded by like lunar shaped dark pink or purple, that's serous demilunes, crescent shaped serous cells surrounding the mucus acini. Okay, it is crescent shaped. Okay, the differentiating feature for submandibular gland that it's mixed of serous acini and mucus acini, and it has serous demilunes, which is a crescent shaped serous acini surrounding the mucus acini. Finally, we have the sublingual gland, and sublingual is full of mucus acini, and mucus acini are light pink. So sublingual gland found under the tongue in the sublingual fold. If you remember, we have the tongue, the frenulum, and the sublingual chronicle, and then we have sublingual folds. Sublingual gland in the sublingual folds, not the sublingual chronicle focus. It's not surrounded by fibrous capsule. It's the only one that's not surrounded. بس يعني بصراحة not very important information. And it's made of mucus acini only, which is light pink. So differentiating feature, mucosa acini only, which looks light pink. As you can see here, that's light pink. Is everything clear? You may say, oh, this is dark pink. No, that's not, that's the duct. As you can see here, it's a lumen surrounded by cells. This is the acini, which look like a flower. Now we will
Yes.
start with the pharynx. So, as we said, we have the oral cavity. Let's use this one. We have the oral cavity, and then the tongue, and then the food will reach here. We need a tube that takes this food down to the stomach. And the first part of this tube is the pharynx. So the pharynx is a tube that's connected to both the nose and the tongue, or the oral cavity. It will take both air, food, and fluid down, okay? It will take them either to the esophagus, which will continue to the GI tract, or the larynx and trachea, which will continue to like the lungs, okay? So, on the other hand, larynx is located below the pharynx, okay? It's here, located below the pharynx. And it connects the pharynx to the trachea only, okay? So, we have the pharynx connected to either the esophagus or the larynx. The esophagus will continue to the stomach. The larynx will continue to the trachea, to the respiratory system. Okay, so the flow of the air is either the nasal or oral cavity, because some people breathe from their mouth. You know, when your nose is closed, you will breathe from your mouth. So air will move through nasal or oral cavity to the pharynx, then the larynx, then the trachea, then the lungs. However, the food will move from oral cavity to the pharynx, like it doesn't go to a nasal cavity. Okay, no one eats from their nose. Food will move from oral cavity to pharynx, then to the esophagus, then to the stomach. Okay. Now, what if we ate here? Why this food doesn't go to the trachea? Why does it go to the esophagus? Because we have a cartilage here called epiglottis. When you swallow, this epiglottis will close and it will prevent food from going to the trachea. It will only allow it to go through the esophagus. Now, the pharynx has three parts. We said the pharynx is connected to the nose. That's the first part, the nasopharynx. Then the pharynx is connected to the mouth. That's the second part, the oropharynx. And then the third part, which is connected to the larynx and the esophagus, called laryngopharynx. Okay? First, we have the nasopharynx. Nasopharynx connect the pharynx to the nose. Okay? As you can see, we have three important structures. The first one is the pharyngeal tonsils. They are a lymph node or tonsils in the pharynx. They are the most superior tonsils. So think, nasopharynx is the most superior, and it has the pharyngeal tonsils as the most superior tonsils. And when they are inflamed, it's called tonsillitis. Okay? Then we have something called ostian tube. Ostian tube is a tube that's connected between the ear, the middle ear, and the pharynx. And this is the ostian tube. Okay? And finally, the tube itself have tonsils above it. Since it's above it, what's going to be called? Tubal tonsils. Okay? These are the second in order. So now let's talk about the oropharynx. Oropharynx is connected between the mouth and the pharynx. Okay? It has the posterior 1/3 of the tongue. We said the anterior 2/3 is in the oral cavity. Then where is the posterior 1/3 and the base? They are in the oropharynx. And it also has the uvula. If you remember, the mouth was like this, and there is a structure here called uvula. And the uvula is the one responsible for gag reflex. It also helps in like saliva secretion, but the most important thing is gag reflex. So the oropharynx has the posterior 1/3 and the base of the tongue. It has the uvula. And finally, it has the palatine tonsils. They are the tonsils at the palate. Okay, that's the third in order, the palatine tonsils. Then we have the laryngopharynx, which has the epiglottis. That's the only thing important. Epiglottis is the one that prevents food from entering the larynx. Now, as I said, we have the pharyngeal tonsils, tubal tonsils, and palatine tonsils. We have also one last tonsils called lingual tonsils. They are just under the tongue, and that's it. Now I want you to focus on this. We have the pharyngeal tonsil ring. Okay, it's the ring that makes all the tonsils. Tonsils are either on both sides or fused together. Okay, so first, the most superficial one, as we said, is the pharyngeal tonsil. Okay, and it's fused together. Then we have the tubal tonsils, one from the left ear, one from the right ear. Okay, then we have the palatine tonsil, the one on the lateral side of the mouth. And finally, we have the lingual tonsil, one fused under the tongue. They may ask you to order them, and the order is pharyngeal, tubular, palatine, and lingual. I hope the picture is clear. Now let's talk about the muscles. So like the tongue, the muscles of the pharynx can be either constrictors, which is intrinsic, like the one that makes the pharynx itself, or straps, which is extrinsic, that attach to the pharynx. So first we have three constrictor muscles. Okay, these are the intrinsic muscles of the pharynx. They are superior, middle, and inferior constrictor muscles. Easy, صح? Always the instructor muscles, intrinsic, muscles are easy in name. Superior, middle, and inferior constrictor. Now we have three extrinsic or strap muscles. Since they are extrinsic, they originate from outside and then attach to the pharynx. So the name is going to be two names. The name of the origin, then the name of the attachment. And pharynx is pharynges. So first we have stylopharynges, from the styloid bone to the pharynx. Here, from styloid bone to the pharynx. Then we have palatopharynges, from the palate to the pharynx. And finally, salpinopharynges. Salpino means tube, so it's from the tubes, chin tube to the pharynx. So we have 6 types of muscles in the pharynx. 3 are intrinsic or constrictors, which is superior, middle, and inferior constrictor. And 3 are extrinsic, which is from outside and attached to the pharynx. So first we have stylopharynges from styloid bone, palatopharynges from the palate, and salpinopharynges from the ostian tube. As you can see here, these are constrictors. They go from both sides and attach together like a circle, okay? So first we have superior constrictor, middle constrictor, and inferior constrictor. Here we have a muscle that goes from the styloid bone to the pharynx, so it's going to be stylopharynges. Here we have from the palate to the pharynx, palatopharynges. Here we have from tube to the pharynx, salpinopharynges. Okay. Now we will go to the esophagus. So as I said, esophagus is a muscular tube that connects the pharynx to the stomach, okay? It's only food pathway. Only the food and liquid will go through it. The esophagus is fully muscular and it has 2 types of muscles, skeletal muscle and smooth muscles. Skeletal muscles are muscles that we control by our own, okay? Like my hand, I'm moving it. Smooth muscles are muscles that we can't control. They move involuntarily and they are like in the organs and stuff. The esophagus is divided to 3 parts based on the muscles. Upper 1/3, middle 1/3, and inferior 1/3. The upper 1/3 is made of skeletal muscles only. That's why you can't swallow. You get it? Because the upper part is controlled by skeletal muscles. You can't control the esophagus from upper part. And that's the initiation of swallowing. Then the middle part is both skeletal and smooth muscles, okay? Then the lower part is only smooth muscles. That's why when the esophagus enters to the stomach, you can't control it. Get the point? So esophagus is a muscular tube connect the pharynx to the stomach. It's made of 3 layers. Upper, middle, and lower. Upper, skeletal muscle only. Middle, mix. Lower, smooth muscle only. Esophagus starts at C6, which is the part that it fuses with the pharynx, and end at T11. After passing the diaphragm at like T11, it will fuse with the stomach, and that's it. Okay? The esophagus is the most posterior structure. Larynx or trachea and all of this is in front of it. Okay? Esophagus is the most posterior and it is related to the left atrium of the heart. I think you guys finished CVP. So the left atrium is the most posterior structure. If it's dilated, it's gonna compress the esophagus and cause dysphagia or inability to swallow. Esophagus is divided also to 3 parts, but it's not based on the muscles. It's based on its relation with other structure and blood supply. There is the cervical part, thoracic, and abdominal. Cervical means it's related to the neck. So esophagus goes from the neck to the chest to the abdomen, and there it ends with the stomach. The part that is in the neck, cervical. The part is in the chest, thoracic. The part in the stomach, abdomen. Okay? Now the blood supply of the esophagus. The esophagus, as we said, is divided to 3 parts: cervical, thoracic, and abdominal. The cervical is like at the neck, okay? So the blood supply of it will be related to something else in the neck. The esophagus is most closest to the thyroid gland. It's like under it. So the artery that supplies the cervical esophagus is the inferior thyroid artery, okay? Because it's very close to the lower part of the thyroid gland. So inferior thyroid artery supplied cervical esophagus. Then we have this thoracic esophagus. It moves next to the aorta. Okay, as you can see here, we have the aorta and the esophagus. It's very close. So, يعني, there is no need to another artery to come. It's just esophageal branches from the aorta. And finally, it will join the stomach. And so the blood supply will be from the stomach. It's called left gastric artery, and it's part of the celiac trunk, which we will talk about later. Now, the venous supply. The blood supply, the arterial supply, and the venous supply usually always the same, except in like some few يعني, differences. So the cervical esophagus was supplied by inferior thyroid artery, right? So it's going to be drained by veins by inferior thyroid vein. It's the same. Okay? And the abdominal esophagus was supplied by left gastric artery. Now it's going to be by left gastric vein. You want to memorize this plus minus inferior phrenic vein. Phrenic means diaphragm and it's close to the diaphragm. That's why also it's drained by the diaphragm vein. But يعني, that's your choice. The left gastric is the most important. However, in the thoracic esophagus, we have supply from the aorta. But there is no aorta in the veins. يعني. There is other structures, such as vena cava and stuff. So it's supplied by azygous and hemiazygous veins that drains to the inferior and superior vena cava. So the blood supply of the esophagus. Cervical, arterial is inferior thyroid, veins is inferior thyroid vein. Down part, the abdominal, left gastric artery and left gastric vein. However, the middle part by arteries is by aorta. For the veins is by azygous and hemiazygous, which drain into inferior and superior vena cava. Now the lymphatic drainage. As I said, anything in the head and neck area. And cervical esophagus is part of the neck area. So it's going to be by deep cervical vein. So the first part of the esophagus, the cervical one, will drain into the cervical nodes. Then the thoracic region or the mediastinal region is going to go to the posterior and superior mediastinal nodes. And finally, the abdominal region is going to drain to the celiac node because, as I said, it's supplied by left gastric artery, which comes from celiac trunk. So it's going to drain to the celiac node. I hope it's clear. The cervical part, it's in the neck, so cervical nodes. The thoracic part in the mediastinal nodes. The abdominal part by celiac trunk, so by celiac nodes. Is it clear? Now let's talk about constrictions of esophagus. So esophagus is a tube that moves all the way from the upper part of the GI tract to the stomach. And it will meet many structures. It will meet the aorta where it's do the arch. It will meet part of the bronchus. And trachea will divide to two parts and it will do this. It will also meet the pharynx at the beginning. And then the final part, it will meet the stomach. Every time it meets another structure, it constricts, okay? Because that structure pressure it. So I want you to memorize these levels. First, as I said, esophagus originates at C6. Where is that? At the pharynx. So first we have the pharyngeo-esophageal constriction. First constriction is where the esophagus and pharynx are related. Pharyngeo-esophageal constriction, where at the beginning of esophagus, which is C6. Then we have the aortic constriction. You know, the aorta go and do an arch. This will compress the esophagus. That's the aortic constriction. It's also closest to the left atrium. Left atrium also puts some pressure and cause constriction. So that's at the level of T4. So if they asked you the aortic constriction or the constriction due to left atrium, at which level? That's T4. Then we have the left bronchus right under the aorta. It will compress the esophagus. So that's the left bronchial constriction. That's at T6. And finally, the esophagus will go through the diaphragm before entering the stomach, and that's at T10, the diaphragmatic constriction. So we have 4 constrictions of esophagus. First, at the pharynx level, pharyngeo-esophageal constriction. That's where it originates, C6. Then, where the aorta do the arch, or the left atrium pushing the esophagus. That's aortic constriction, T4. Then the bronchus, left bronchus, will push the esophagus. That's T6. And finally, before it ends at T11, it will pass the diaphragm, and that's the diaphragmatic constriction, which is at T10. A good way of memorizing this, and I remember I was doing this, the final point is T10, okay? So we need numbers that makes 10. So we have 6 plus 4, 10. And 4 plus 6, 10. So I just memorized, it starts at C6 and the end point is 10. And I need structures that makes 10. So 6 plus 4, that's 10. And now we have 4. 4 plus 6, that's 10. That's how I memorize that. I mean, that's not the best way. So I hope you memorize this by your name, okay? Especially the aortic and left bronchial, they are the most asked. This is also a picture usually comes. So here is the first constriction with the pharynx. Here is the aortic. Here is the left bronchus, and under this gonna be the diaphragm and the diaphragmatic one. Here, as I said, the end point is 10, and it starts at 6. I need numbers that makes 10. 4, 6. 4 plus, you get the point. That's it. Now let's talk about the esophageal sphincter. As I said, the esophagus is made of muscles. We have sphincters, which is like a gate, open and close, okay? When it opens, it will allow food to enter. When it closes, it will not allow food to pass the esophagus. The esophagus has two sphincters, one upper sphincter and one lower sphincter at the stomach. Okay? The upper sphincter, since the upper part is made of skeletal muscle, we can control it. So the upper esophageal sphincter is voluntarily controlled because it is made by skeletal muscles and it's at the beginning of the esophagus. However, the lower one is made only by smooth muscles. That's why we can't control it. Okay? When the food enters and we swallow, the upper one will relax. The food will move. And then when it reaches the lower one will relax by its own and the food will enter to the stomach. Imagine the lower one very strict and is not relaxing. The food will accumulate here and this one will be very narrow, and that's called achalagia. Achalagia is the inability for the lower esophageal sphincter to relax. It's going to be constricted all the time, and so the food will accumulate here. We do something called barium swallow where they drink like barium, which is white structure, and we take an image, and if we saw this sign, which is called bird beak sign, because I don't think you need to know this, it is confirmatory of achalagia. As you can see here, this is the esophagus, and here is the lower esophageal sphincter, and it's very, very constricted, not allowing food to enter, and so it will accumulate, and this is achalagia. Okay, now we will talk about the esophagus histology. Okay, now we have different types of epithelium, right? We have stratified squamous, and we have simple columnar. These are the two important epithelium in the GI tract. From the upper part till the esophagus, all of things are stratified squamous. So the oral cavity, the tongue, the esophagus, the pharynx, all of them are made by stratified squamous epithelium. Okay? From the stomach downward, all of them are made by simple columnar epithelium. Keep this in mind. From the tongue and oral cavity till the end of the esophagus, everything is made by stratified squamous epithelium. From the stomach downward, everything is made by simple columnar epithelium. Okay? So, let's start with the esophageal histology. It's like all other part of the GI tract, made of 4 parts. First is the mucosa. And what's the epithelium? Stratified squamous epithelium. Okay, and all of them non-keratinized, by the way, except the filiform, that's keratinized. Everything else is not keratinized. Stratified squamous epithelium. And then it has lamina propria, muscularis mucosa, and so on. Then we have the submucosa. It has connective tissue, gland, and so on. And see the glands in the submucosa, not mucosa. Then we have muscularis externa, which has 2 muscles. Inner circular, which appear longitudinal, and outer longitudinal, which appear circular. I already explained this. I won't go through it again. And then adventitia, which is dense tissue or whatever. Okay? Please memorize this picture by heart. This is the esophagus, okay? They may get you the picture from here, only this part. Once you see from the inner side, like this, that's esophagus, definitely. Okay? How do you know esophagus? It has stratified squamous epithelium, okay? And then it have a very big 2 muscular layer, inner, circular, outer, longitudinal. That's the esophagus. Lumen in the inside. Then the mucosa has stratified squamous epithelium because all other parts have simple columnar except the tongue. And the tongue, we already know it's histology. So any picture with stratified squamous epithelium and it's not the tongue, that's the esophagus. And it has very big muscular layer, that's the esophagus. Now we have something called gastroesophageal junction. Imagine this, we have the esophagus and it's stratified squamous epithelium. And it suddenly meet the stomach, which is simple columnar epithelium. If we took this part in histology, we will have a sudden cut or sudden change from stratified squamous epithelium to simple columnar epithelium. Where does that happen? That happens in the gastroesophageal junction. It's the junction between the esophagus and the stomach. and we see sudden change from stratified squamous epithelium to simple columnar epithelium. So esophagus epithelium, stratified squamous, stomach and all other GI tract, so on, simple columnar epithelium. Gastroesophageal junction that connects the esophagus with the stomach. What's the histology? Sudden change from stratified squamous epithelium to simple columnar epithelium. But what's the function of this junction? It allows the food to pass from esophagus and stomach. Simple, okay? And you don't overthink it. So if you saw sudden change from stratified squamous to simple columnar, esophageal gastric junction or gastroesophageal junction. Don't use this name. Use this name, gastroesophageal junction. Okay? Clear? Because I'm sure it's gonna come in the OSPE, this one or another junction. It came in our exam and it was the real microscope and you need to look and it was like tough. So memorize this by heart. Sudden change from stratified squamous to simple columnar, that's definitely gastroesophageal junction. As you can see here, that's stratified squamous, that's simple columnar. Now let's start with the stomach. As we said, the esophagus will take the food into the stomach. The stomach histology is going to be simple columnar epithelium. What's the function of the stomach? It will digest food and so on. Okay, let's start. So the stomach comes after the esophagus. Where is it? Under the diaphragm. Esophagus move under the diaphragm, it will meet the stomach. Okay. The stomach has, look at the stomach, it's very small and it will digest all the food that you took. How is that possible? Because the stomach has multiple folds called rugae, okay? And these multiple folds will increase the surface area. Just imagine this, you have this line, let's say it's 5 centimeter, okay? And you have a line like this. They are the same length if you looked at it, but this one is gonna be, let's say 20 centimeter. So, the stomach has multiple folds inside it. It's not like linear shaped, it's folded, okay? These folds called rugae, and it increased the surface area of the stomach so it can digest more food and expand. And once you took the stomach and, if you took this line and stretch it, it will stretch and it would show you the real 20 centimeter. The stomach, although it may appear small, it can expand because it has multiple folds inside it called rugae, which increase the surface area. The stomach itself has multiple parts. The esophagus came here and it met the stomach. The first part after the esophagus meeting is the cardia. Just memorize this. It's just called cardia, the part after the esophagus. The upper part, which is usually full of gas, okay, because the food will go here and by the gravity it will go down. If the stomach is not full, the upper part is the one full of gas and it's called fundus, okay? Fundus is the upper part of the stomach and it's full of gas. Then we have the body, which is the middle part. And finally, we have the pylorus, which is the last part of the stomach, which meets the small intestine or like the duodenum. Okay, this is the pylorus. And it has also a sphincter to control everything, moving from the stomach to the duodenum. It's called pylorus. It also have two curvature. Curvature mean curve. Okay, it has two curvature. First one is the lesser curvature. It's small. And then we have the greater curvature, which is very big. So you have two curvature in the stomach, lesser, which is small, and greater, which is very big. Here you can see lesser, bigger, greater curvature. Here cardia, here fundus, here body, here pylorus. As you can see here, this is the stomach, but barely you can identify. This is the pyloric sphincter, and here is the duodenum. I don't think you will be asked about this. This picture, if you want to memorize everything, like the cardia notch, the pyloric antrum means entrance, so the entrance to the pylorus, then the pylorus orifice, which is the outrus of the pylorus. If you want to memorize, I don't think you need all of this. Just cardia, fundus, greater, lesser curvature, and so on. Now let's talk about the blood supply. My friend will talk about blood supply too, but I think you really need to memorize them by heart. So we'll explain them twice, okay? So here we have the aorta, okay? And the aorta will give three structures. First one is called celiac trunk. This is the celiac trunk. Then it will give superior mesenteric artery. Then it will give inferior mesenteric artery, okay? Superior and inferior mesenteric artery are related to the intestine, so we don't need them. Okay, we will only talk about the celiac trunk. Okay, this is the celiac trunk. Celiac trunk is made of three blood vessels. Okay, celiac trunk, it's a trunk that gives three blood vessels. These blood vessels are memorized by the mnemonic left-hand side. Memorize this, left-hand side. Okay, now we'll talk about them. So let's repeat. Left hand side. L is for left gastric artery supplying the lesser curvature. The H is for common hepatic artery. Common hepatic artery will give hepatic artery proper that goes to the liver and the gastroduodenal artery. Gastroduodenal artery will supply the stomach and the duodenum. Now, the hepatic artery will give something called right gastric artery because if we have left gastric artery, we need a right gastric artery. So the hepatic artery proper will give right gastric artery, which will meet the left gastric artery, and that's the whole supply of the lesser curvature. Then the gastroduodenal artery will pass behind the duodenum, and it will give something called gastro-epiploic artery or gastromental. I prefer saying gastro-epiploic artery, which will supply the greater curvature. Then we have side, the S for splenic artery. Splenic artery will go to the left because the spleen is on the left. So it will go all the way to the left. And it will give two arteries. One called short gastric artery, supplying this upper part of the stomach, which is the fundus. So what's the fundus supply? Short gastric artery and the left gastro-epiploic artery. Now, as I said, we have the celiac trunk and it gives three arteries. Right one is the common hepatic, middle to left one is left gastric, and left one is splenic. As you can see, it makes an M shape. Okay, here, like M shape. So they may give you this picture or on the cadaver with an M shape and ask you what's this, and what's that. As I said, the one going to the right is common hepatic artery. Why? Because the liver is on the right. The one going to the left is the splenic artery because the spleen is on the left. The one going mid-left is left gastric artery because the stomach is in the middle to the left side. Okay, so the stomach blood supply is by the celiac trunk. Celiac trunk has an M-shape arteries. First one is on the right side, common hepatic. In the mid-left side, left gastric. On the left side, splenic artery. Clear? Now let's go to the stomach histology. Stomach, like anything in the GI tract, made of four layers: mucosa, submucosa, muscularis externa, and adventitia. However, all of them have glands in the submucosa, except stomach. Stomach has it in mucosa. Why? Because stomach needs to digest everything very fast. So all organs have the glands in the submucosa, except the stomach. It has it in the mucosa. Okay? Why? Because it needs to digest everything very fast. Now, what's the mucosa? Simple columnar epithelium. We said this, the epithelium of the stomach, simple columnar epithelium. With the epithelium is organized in folds called rugae. As you can see here, the epithelium is not very straight. It's rugaes. By the way, it's not these things only. It's the whole thing itself. It's folding. Okay, so that's rugae. And increase surface area of digestion. And as you can see, if you have a rugae, which is like if you have a projection, you will have a depression, and the depression called gastric pits. And here where the glands are, okay? So the stomach epithelium is simple columnar epithelium. It has rugae, okay? Rugae is like projections. And if you have a projection, you will have a depression. The depression is called gastric pits, and here are the glands in the mucosa, okay? This is the heavy slide, okay? We have three cells or three glands in the stomach, okay? So again, the mucosa, simple columnar epithelium. It has three types of cells or glands, okay? Each one has its structure and like function and so on. The first one called mucous neck cells. They are at the neck of the crypt. So if you have a rugae and then it goes down and goes up, this is the neck. So mucous neck cells are there. They are in the neck. From the name, mucous neck cells. They are in the neck and they secrete mucus. Mucus is not important for digestion. It's more of like lubrication and so on. So where are they? At the neck of the gland. Their nucleus, how is it? Central or basal? Both. It can be like the nucleus can be in the middle or it can be on the side. That doesn't matter. For mucous neck cells, they are at the neck. They secrete mucus and their nucleus is in the center. Now we can do electron microscopy to see the cell itself with its nucleus and everything. And these mucous neck cells have granules at the bottom. Granules are black structures that have like the mucus, and they are at the bottom. Okay, so three things for mucous neck cells. From the name, neck cells, so they are at the neck. Mucus neck cells, they secrete mucus. And they have granules at the bottom. Okay, I'll show you pictures later on. Then we have the parietal or exentic cells. This parietal, use parietal, okay? Parietal cells. They look pink, eosinophilic, okay? So the parietal cells are pink. From the name, PP, parietal is pink, eosinophilic. They secrete HCl and intrinsic factors, which is important for vitamin B12 absorption. They may ask you which of the cells are important for vitamin B12. Parietal cells. Why? Because they give intrinsic factor. So parietal cells, they look pink. They secrete HCl and intrinsic factor for vitamin B12 absorption. Where are they? On the upper part of the glands. If you have this whole thing, it's in the upper part. Okay? What about their nucleus? The nucleus is in the center only. It's fried egg appearance. Fried egg looks like this, okay? And if we did electron microscopy, it will have a lot of mitochondria. Mitochondria in electron microscopy looks like this, a structure with many lines, okay? And finally, I know everything is chaotic. I'll show you pictures and explain on them again. Finally, we have the chief or peptic cells. They are blue, okay? Chief cells are blue, basophilic blue. They secrete pepsinogen, which is important for the protein digestion. Where are they? If parietal cells are at the top, then chief cells are at the bottom, okay? The nucleus is basal, like blue basal, you get the point. And the granules are at the top. So what does that mean? Let's look at this picture. We said we have three types of cells. First, we have mucous neck cells. This is a gland, and here it goes up. Here we will have mucous neck cells at the neck. Okay? And we have the parietal cells. They are on the upper part. So if we divide this picture to two parts, upper and lower part, the upper part is the parietal cells. As you can see, the nucleus is in the middle, fried egg appearance, and they are pink. Finally, we have the chief cells, which is on the lower part, and they are blue, and the nucleus is on the side. So this one is parietal cells because they are pink and they look like fried egg appearance, which has a nucleus inside. Now, what does this mean? Granules at the bottom, multiple mitochondria, granules at the top in electron microscopy. This is electron microscopy, okay? It shows the cell from inside itself, okay? And here, light microscopy, we only see the nucleus. Electron microscopy will see everything. If you see multiple granules at the top, that's chief cells, okay? Multiple granules at the top, chief cells, okay? Want a way to memorize this? Remember, a chef will wear a hat. This looks like a hat. So chief cells have the granules on the top. Then we have mucous neck cells. They have the granules at the neck from the chef. So they are down, okay? And you get the point. The granules in chief cells, since the chef wear their hat above, then it's at the top. Mucous neck cells, the granules are at the neck, so they are down, okay? And parietal, the granules are all over the place, but that's not what matters. It has multiple mitochondria and caniculi. So this is mitochondria. See, there are so many lines here. See, there are so many lines. Ignore the granules. There are so many lines here. That's mitochondria and that's parietal cells. So if you saw granules at the top, chief cells, granules at the bottom, neck cells. If you saw multiple lines, parietal cells. Is this clear? Now let's talk about submucosa. Mucosa has multiple blood vessels and connective tissues and no glands. There is no glands because the glands are already in the mucosa. Then we have muscularis externa. Previously, muscularis externa had two layers, inner circular, outer longitudinal. In the stomach, it has three layers. We have the inner circular and outer longitudinal, but there is more inner part, which is inner oblique. So previously we have inner circular, outer longitudinal. In the stomach, we have a new part called inner oblique. Okay, so innermost layer is inner oblique, middle is inner circular, and the outer is the longitudinal. As you can see here, it's inner oblique. You see, it's oblique, and the rest, they are down. Okay, not the most important feature, بس يعني if they ask you give me differentiating feature for this thing, you can say the rugae, you can say glands at the top, you can say simple columnar epithelium, and you can say three muscle layers. Okay, they will usually ask for one feature or two features. Now, the whole thing was very chaotic, I would say, and confusing. So this is a table that summarized the mucous neck cells, parietal, and chief cells. Mucous neck cells, their stain, we don't care if they are pink or blue. The nucleus is basal or center. It's at the neck of the gland and give mucus. Parietal, they are pink. The nucleus is central, so fried egg apparent. They are at the upper part, secrete HCl and intrinsic factor for vitamin B12. Chief cells are basophilic, which is blue. The nucleus is basally, so it's outside. It's lower part of the gland and secrete pepsinogen. One more thing on electron microscopy. If you saw granules down, that's mucous neck cells. If you saw granules up, that's the chief cells. If you saw mitochondria and multiple lines, that's parietal cells. Final part in the stomach. So as we can see here, this is the stomach, okay? And it will now join the duodenum. And we have gastro-duodenal junction. It's the junction between the stomach, pyloric part, and the duodenum. Here we have something called pyloric sphincter. It's muscles that control the fluid and food movement from the stomach into the duodenum. But if we looked at the gastro-duodenal junction, what we will see? We will see a sudden change from the gastric histology to the duodenal histology. It's tough to explain this without explaining the duodenal histology, but bear with me. So stomach histology is simple columnar epithelium. Duodenal histology is also simple columnar epithelium. طب how will I differentiate between these two things? The stomach has no submucosal gland. The duodenum has a very big submucosal gland called the Berner's gland. So that's how to differentiate. Here we have the stomach epithelium, as you can see. It's just simple columnar. And here it's the duodenum. It's also simple columnar. It's tough to differentiate here without anything else. However, here, I know the picture is not the best, but here we have also simple columnar, but here we have a bigger structure in the submucosa, as you can see. And here submucosa is empty. Here we have big structures. That's the Berner's gland, okay? Also here we have the rugae. In the duodenum, there is no rugae, there are villi. So, how to explain this? The stomach have simple columnar epithelium and rugae. However, the duodenum is villi. Villi are like this, projections, very, very strong projections. So once you see change from simple columnar and rugae to villi, that's gastro-duodenal junction. Also, if you saw these things, which is the Berner's gland, the submucosal gland, that's the duodenum. That's the sudden change. Once I explain the duodenum, it will be more clear. Now, I want you just to differentiate between esophageal gastric junction or like gastroesophageal junction and the gastro-duodenal junction. As you can see here, it's a change from stratified squamous epithelium to simple columnar epithelium. This is going to be gastroesophageal junction. Here, it's a change from simple columnar to simple columnar. That's the gastro-duodenal junction. Also, it's changed from simple columnar to simple columnar with villi. That's gastro-duodenal junction. Here, change from simple columnar to simple columnar with villi and like very big submucosal glands. That's gastro-duodenal junction. All right, now we will talk about the intestine. So as I said, the food will reach the stomach and then the pyloric sphincter, and then it will reach the small intestine. So the small intestine divided to three parts: duodenum, which is the first part, jejunum, and then ileum. The duodenum, its first part supplied by gastro-duodenal artery. We already talked about gastro-duodenal artery. It passed behind the first part of the duodenum, so it will supply it. The rest is supplied by superior mesenteric artery, then the jejunum, superior mesenteric artery, and the ileum is also superior mesenteric artery, MSA mentioned. No, SMA, should we SMA? Now let's talk about generally the small intestine histology. The small intestine is similar to all other parts, have four parts: mucosa, submucosa, and so on. The mucosa is made by simple columnar epithelium. However, there are new structures now we will have in the small intestine. First, we will have villi. Villi are these projections. very thin projections that يعني will increase the surface area. They are on top of the simple columnar epithelium. First we have villi. Then we will have crypt. If you have a villi, you will have a crypt. The villi is the upper projection, then the crypt is the downward projection, okay? They are between the villi and they will receive the secretions from the submucosal gland. Then we have something called goblet cells. Goblet cells will secrete mucus, okay? It will just help for lubrication and so on. Then we will have something called plica circularis. Plica circularis is similar to the concept of rugae. If you have a line like this, that's 5 centimeter, then you will have lines like this, that's let's say a total of 20 centimeter. It's the same thing as rugae. It's plica circularis, it's fold in the mucosa and submucosa that will increase the surface area. طب how it is different than يعني rugae? The rugae, if you stretch it, the whole thing will be stretched, okay? And you will reach the 20 centimeter. However, here, if you stretch it, it won't stretch. It will stay the same, okay? So this won't actually end up as 20 centimeter as a whole line. It's يعني I hope you get the idea. Rugae are stretchable. So if you stretch it, the whole thing will be stretched. Plica circularis doesn't يعني is not stretchable, okay? So that's the difference, okay? Duodenum has some plica circularis, jejunum has a lot, and ileum has no plica circularis. And plica circularis are like longitudinal projections, so it only appear if you cut it longitudinally. If you cut it in a cross section, you can't identify it. Please memorize this info because they will ask you, what's this? You will say plica circularis. They will ask you, how did you know? Or what's the cut? You will say longitudinal cut. This is another picture of plica circularis. So this is the villi. That's not plica circularis. Plica circularis is the whole thing being folded, okay? Not just these folds. No, the mucosa and submucosa are folded. That's plica circularis. If you wanted to flex it or stretch it, it won't, okay? That's plica circularis. It's only appear in longitudinal cut. Literally, this picture, they will bring it in the exam. What's this? Plica circularis. What's the cut? Longitudinal cut. Now the duodenum has 4 parts. Here is the stomach and it will attach to the duodenum. The upper part of the duodenum called superior part because it's the most superior. And if the upper part is above and everything is down, then the second part should go down and it's going to be the descending part. So the duodenum made of 4 parts. The first part is the most superior, so it's called the superior part. And it has 2 inches, first inch and second inch. First inch is peritoneal. The rest is retroperitoneal. My friend will explain more on this. Then we have the descending part. Then we have a transverse part, then we will have an ascending part, then it will join the jejunum. All duodenum parts are retroperitoneal. So if you have a peritoneum, they are behind the peritoneum. Except the first inch of the first part is peritoneum. So it's surrounded by peritoneum from both sides. That's only the first inch of the first part. Why is it peritoneal? Because it's surrounded by something called hepatoduodenal ligament. Okay? Let's explain more on this. We have the peritoneum that surrounds the organ. Some organs are behind it, some organs are in it, some organs are not related to it. And then we have the hepatoduodenal ligament. It's a peritoneum that extends from the liver to the duodenum. As you can see here, we have the liver and this is the duodenum, and this a peritoneum that extends from the liver to the duodenum. That's hepatoduodenal ligament, and it will surround the first part of the duodenum. That's why the first inch of the first part is considered peritoneal, because it's surrounded by hepatoduodenal ligament. So hepatoduodenal ligament connects the liver, hepato, to the duodenum, okay? It contains 3 important structures. It's not just a ligament and peritoneum that connects the liver and the duodenum. It has 3 important structures. These structures, mnemonic is DVA. D is the common bile duct. V is the portal vein, and A is the hepatic artery proper. So it has 3 structures: an artery, a vein, and a duct, okay? The mnemonic is DVA. D is the duct, common bile duct, V is the vein, portal vein, and A is the artery, hepatic artery proper. DVA is ordered based on the most right to the most left, okay? So D, duct, is the most right, then V, vein, is in the middle, and A, artery, is on the left side, okay? Also, the V, the portal vein, is most posterior. So if you look from it from anterior side, it's the most posterior. If you looked from behind, it's going to be the most prominent, okay? Please memorize these things. Okay, clear? Now, the duodenum, it has specific blood supply, SMA, whatever. I'm not related to this, but we have the gastro-duodenal ligament, which passes behind the first part of the duodenum. Gastro-duodenal ligament passes behind it. So if I injured the first part of the duodenum posteriorly, it will damage the gastro-duodenal ligament. So if we have ulceration or damage to the first part of the duodenum, we will have damage to the gastro-duodenal artery and the risk of bleeding. Finally, we have something called ligament of threads. Ligament of threads is made from the diaphragm. The diaphragm has two crusts, right and left. The right will give a ligament called ligament of threads, and it attached to the last part of the duodenum, which is the fourth part. As you can see here, we have the superficial and the descending, transverse, and then ascending. Why is the last part ascending anyway? Because it's attached to this ligament. This ligament is pulling it upward. That's why it's ascending. Okay. So ligament of threads is a ligament that attached to the fourth part or the ascending part of the duodenum, and it's supported and anchored, preventing it from malrotating or moving. Okay. If we have a defect of ligament of threads, we will have intestinal malrotation or twisting. This part will twist around the other parts. Now, let's talk about some relations of the duodenum. So here we have the stomach, and it's attached to the duodenum. Then the duodenum will go like this and circulate around the pancreas. Also, the duodenum, you shouldn't be able to see it because the liver should be covering it, but here they did cut it. So what are the relations to the duodenum? Anteriorly, like in front of the duodenum, we will have the quadrate lobe of the liver and neck of gallbladder. Normally, we shouldn't be able to see this because the liver should be covering it with the gallbladder. So anteriorly to the duodenum, we have the quadrate lobe of the liver and neck of the bladder. Now, what about behind it? Behind it, we will have the structures of the hepatoduodenal ligament, such as the bile duct and the portal vein. The artery is not related because it's on the left side, it's very far. We will also have the gastro-duodenal artery because we said it passed behind it. We also have inferior vena cava and lesser sac, not the most important. Most important are the two structures of the hepatoduodenal ligament, bile duct and portal vein, because they are medial. Not medial actually, they are on the right side, so they are at the duodenum. And we have gastro-duodenal ligament because it passes behind it. Superiorly, we have something called epiploic foramina. My friend will explain it later on. It's a foramina between two openings of the peritoneum. And inferiorly, we have the pancreas. Under it, there is the pancreas. So anteriorly, liver and gallbladder. Inferiorly, pancreas. Posteriorly, epiploic foramina. Superiorly, epiploic foramina. And posteriorly is the bile duct, the portal vein, the gastro-duodenal ligament. Now, one more thing to mention. The duodenum, we said, has four parts. In the second part, which is the descending, we have the bile duct and the pancreatic ducts entering at it. I will explain this later on when I explain the gallbladder, but the gallbladder here have a duct, and then the liver will give a duct. And these ducts will fuse with the pancreatic duct, and both of these ducts will make a duct, and this duct will open into the second part of the duodenum, which is called duodenal papillae. So for now, we know that the duodenal papillae is the opening of both the bile duct and the pancreatic duct. Where is it? At the second part of the duodenum. But this opening, any opening, is surrounded by a sphincter. What is this sphincter? Sphincter of Oddi. So memorize these things. We have the bladder giving a duct, and then the pancreas will give a duct. These ducts will fuse together and open in the duodenum. Where? In the duodenal papillae. What's the name of the sphincter around it? Sphincter of Oddi. Now let's talk about the duodenum histology. As we said, all the part of the GI tract made of four parts: mucosa, submucosa, sclera externa, and adventitia. The mucosa of the duodenum is simple columnar epithelium. What are the extra structure we have in small intestine? We said the villi, crypts, and goblet cells. Here it's few. Okay. We also have some few plica circularis, which is absent in the first part of the duodenum. Okay. But they are in the duodenum, but not in the first part. Then we have submucosa, and submucosa has blood vessels, connective tissue, and gland. And the most important glands in the duodenum are Brenner's gland. Okay, they are serous glands, so they will appear darkish or dark pink, and they are in the duodenum. These are the Brenner's gland. Here we have the epithelium or mucosa, and here we have the glands in the submucosa. That's the difference between the stomach and the duodenum. The stomach will be attached here. It will have simple columnar, but here it's empty. Here it's full of glands. That's how to differentiate between the gastro-duodenal junction. Okay? So the duodenum, mucosa, simple columnar epithelium with villi, crypts, and goblet cells, and few plica circularis. Submucosa have Brenner glands. That's the most important thing, Brenner's glands. So how do we know we are in the duodenum? Presence of Brenner's gland. That's the most important differentiating thing. There are other stuff, subcolumnar epithelium, villi, crypts, but the most important thing is Brenner's gland. Now, I want you also to appreciate goblet cells. Goblet cells are white, yani more lightish cells in the epithelium. They secrete mucus. That's why they are light, because they will have mucus. Now, we have duodenum, jejunum, and ileum. The goblet cells increase the more we go. Yani duodenum few, jejunum more, ileum very high. Okay? Just keep this in mind. Goblet cells increase the more we go. Now we will talk about jejunum and ileum. Now duodenum moved and now it will fuse with the second part, which is jejunum. And then jejunum will fuse and yani continue with the ileum. Okay? So jejunum and ileum are the continuation of the small intestine. Jejunum is the second part, ileum is the third part. Now I want to explain a concept. Let's assume we have a blood vessel here. And here is the organ. The blood vessel must reach the organ. This is done by two ways. How to reach the organ. First thing is by making arcades. Arcades are like this. We make an arcade, then arcade, then arcade, and then the last blood vessel that reach the organ is called vasa recta. So we either make multiple arcades and have a short vasa recta, or we have no arcades or few arcades and a very long vasa recta. So vasa recta is the last artery that reaches the organ. Okay? Arcades are stuff that we make to reach the organ with a smaller vasa recta. Okay? So appreciate this. Here we have an artery and one arcade and then a very long vasa recta. Here we have an artery, then multiple arcades, and then a very small vasa recta. Okay? The jejunum has very few arcades and a very long vasa recta. On the other hand, the ileum has multiple arcades and a very short vasa recta. Okay? So how to differentiate between jejunum and ileum grossly? Jejunum has one arcade or none and a very long vasa recta. Ileum has multiple arcades and a short vasa recta. Okay? So here, as you can see, we have one arcade and then a very long vasa recta. That's jejunum. Here we have an arcade followed by an arcade, then the vasa recta. So that's ileum. Okay? Now let's talk more about jejunum. Jejunum has few arcades, very long vasa recta, as you can see. One arcade, very long vasa recta. One arcade, very long vasa recta. And it has less fat. So its pictures has more visibility. We can see everything because it barely has any fat. The histology of the jejunum is as follows. It is made of 4 parts, mucosa, submucosa, khasa. I'm done explaining this thingy. But I want you to focus that in the mucosa, it has plica circularis. As we said, it's like the folds. It doesn't have lymph nodes called Peyer's patch. Why I'm mentioning this? Because the ileum has them. It's like a submucosal lymph nodes, whatever. So jejunum doesn't have them. It has something called beneath cells. From the name beneath, but just imagine it beneath being low. I know it's beneath, but just imagine it beneath cells means it's down. So here we have the whole thing, and here we have the crypt, and here we have the beneath cells. Beneath cells are eosinophilic, red cells, and they are found at the bottom of the crypts. There is a name for it, crypt of Lunger or something. I have it in one of the slides. And what are they? They are important for innate immunity. Are they only in jejunum? No, they are in jejunum and ileum. So both jejunum and ileum has beneath cells, which are these eosinophilic cells at the bottom of the crypt. Okay? And jejunum, of course, has more goblet cells than duodenum. Now let's talk about ileum. Ileum have more arcades. As you can see here, many arcades, and then a very short vasa recta. And it has more fat, so the picture is kind of less visible. In terms of histology, it's the same as jejunum, except of two things. It doesn't have plica circularis. However, it has Peyer's patch, which is like here, a patch. See, it's like a patch. It's a lymph node patch in the mucosa. Okay, so that's ileum. Ileum is the same as jejunum. It has beneath cells, as you can see here. but it doesn't have plica circularis. However, it has Peyer's patch. Now, as I said, I'm going to explain more what is Penneth cells. Penneth cells are eosinophilic or red cells found at the bottom of the crypt. What's the name of the location itself? Crypt of Libercan. Okay? Crypt of Libercan. That's the place for the Penneth cells. What's the function? It's part of the innate immunity. It secretes antimicrobials and lysosomes, which kills the bacteria. So, Penneth cells present in both jejunum and ileum. It's found at the crypt of Libercan, which is at the bottom of the crypt. It looks eosinophilic and it's part of innate immunity. It secretes antimicrobial and lysosomes. Now, how to differentiate between each thing, okay? The duodenum, it has villi. All of them has villi, so I want you to ignore this part. The duodenum has villi. It has Brenner glands. Brenner glands are the submucosal gland of the duodenum. Does it have Peyer's patch? No. Goblet cells, low. Plica, low. Jejunum. Jejunum, does it have Brenner's gland? No, it's the only gland for duodenum. Does it have Peyer's patch? No. Does it have goblet cells and plica? Yes, and it has Penneth cells. Ileum. Ileum, does it have Brenner's gland? No, that's only for duodenum. Does it have Peyer's patch? Yes. And it doesn't have plica circularis. I also have these things here. Duodenum has Brenner glands. Jejunum have Penneth cells without Peyer's patch. Ileum has Peyer patches. Okay, so if they give you a picture of duodenum and ask you what's the differentiating feature, it's gonna be Brenner's gland. You must write this. You can write the other stuff, simple columnar, villi, plica, whatever, but the Brenner's gland is what they are searching for. The jejunum, differentiating part, Penneth cells and multiple plica circularis and no Peyer's patch. Ileum, it has Peyer's patch. Okay? How to differentiate between Brenner's gland and Peyer's patch? Peyer's patch is in the mucosa. Brenner's gland is in the submucosa. Clear? Okay, finally we have gallbladder and then Abdul will continue. Gallbladder is a sac connected to the liver. Okay? It has a function of storing and concentrating bile. So bile is fluid made by the liver that help digesting fat. Okay? It's made by the liver. So gallbladder sac next to the liver, store and concentrate bile. Please remember this because in my year I wrote store bile without concentrate and I think they counted wrong. So store and concentrate bile. What's the function? Concentration and storage of bile. What's the histology? That's the most important part here. The histology of gallbladder, as I said, all the parts in the GI is made of four layers, mucosa, submucosa, except the gallbladder. It has mucosa that has epithelium without anything else and muscularis externa. It will have adventitia serosa, but it doesn't have muscularis mucosa or submucosa. So once you see a thing يعني fully unorganized and really weird, that's gallbladder because gallbladder is missing many structures such as the submucosa and muscularis mucosa. That's why it's very chaotic. So once you see a picture that's very chaotic, that's the gallbladder. What are the layers that you are seeing? Just write mucosa muscularis externa, okay? Because it's missing most of the other things. So gallbladder, it has mucosa and it has muscularis externa. It doesn't have most of the other stuff, so that's why it's unorganized. Now the gallbladder is supplied by something called cystic artery. Cystic artery comes from the hepatic artery proper. Memorize these things. Now the bile pathway. Bile is made in the liver. Okay, then it goes to the right and left hepatic duct from the name. The duct is inside the liver. So it's going to be right and left hepatic duct. They will merge together and they will form something called common hepatic duct. Any duct that's made by two or more, that's common hepatic duct. Okay, now we have the gallbladder. It will also secrete the bile into the cystic duct. Okay, because the gallbladder is like a cyst like a sac. So the name of the duct is cystic duct. Now cystic duct and the common hepatic duct will fuse together and make another common duct. But now this duct is the main duct for the bile, so it's called common bile duct. The common bile duct will fuse with the pancreatic duct and they will make something called ampulla of Vater. That's the name of the duct of the fusion of the common bile duct and the pancreatic duct, ampulla of Vater. and both they will open into the, if you remember, the duodenal papillae, which has the sphincter of Oddi. Okay, so how does the bile move? We have here the liver. It will make bile. It goes to the right and left hepatic duct. Fuse, making common hepatic duct. The bladder will make cystic duct. They will fuse and make common bile duct. Common bile duct will fuse by pancreatic duct and open and make ampulla of water. Ampulla of water will open into the duodenum. Okay, that's the bile pathway. I wrote everything here. Is everything clear? Okay. This is just anatomy. Here is the gallbladder. The duct that's connected directly to the gallbladder is going to be cystic duct. The one connected to the liver, hepatic duct. Fused together, common bile duct. Okay? This is also cholangiogram. Yani it's just to see the whole pathway of the bile. Here is the liver. So here we have the right and left hepatic ducts. They will fuse and make common hepatic duct. Here the bladder will give cystic duct. Cystic duct, common hepatic duct will fuse and make the common bile duct. Common bile duct will fuse with a duct called pancreatic duct. Both will open into the duodenum. Memorize these things by heart. Now, finally, gallbladder diseases. The gallbladder may get inflamed and get infected. That's called cholecystitis, which is inflammation of the gallbladder due to infection. Okay? All the rest of the diseases will cause cholecystitis. Cholecystitis, inflammation of the gallbladder due to infection. Why does it happen? Because of the following diseases. First, gallstones. A stone may be formed in the gallbladder. Okay? This stone may have different location. I want you to memorize the names of the locations. First, the stone might be in the gallbladder and it stays. Nothing happens. It's just there. That's called cholelithiasis. Okay? Gallstone in the bladder itself. Okay? Cholelithiasis. Now, if this stone moved and blocked the common bile duct, not the cystic duct, blocked the common bile duct, it will be called cholelithiasis. Okay? Gallstone in the common bile duct. Now, it may block the cystic duct, it may block the pancreatic duct. These doesn't have a specific name. I just want you to memorize these two names. Cholelithiasis is gallstone in the gallbladder itself. Choledo, with the addition of D, it's obstruction of the duct. See, the D came from the duct. So cholelithiasis is gallstone in the common bile duct. Okay? This question came in my exam. I wrote cholelithiasis, so I wasn't sure about my spelling, and Dr. Atif, I remember him telling me, no, maybe it will be correct or maybe not. He ensured that did you wrote the D in the middle. So yeah, gallstones in the gallbladder, cholelithiasis. Gallstone in the duct, cholelithiasis. Treatment, we remove the gallbladder, which is called cholecystostomy, but it's not that necessary. We remove the gallbladder. Now, the gallbladder is supplied by an artery called the cystic artery. If we wanted to remove the bladder, we may injure the cystic artery and we will have a bleeding and the patient will die. Okay? So we need to locate the cystic artery to ligate it, close it, and then remove the gallbladder without damaging it. How do we locate the cystic artery? By something called Calout's triangle. Okay? There is a triangle between the bladder and the ducts and the liver, and this cystic artery moves in it. Okay? So Calout's triangle, it's a triangle used to locate cystic artery. The triangle made of three parts: medial, inferior, and superior. Remember, the apex of this triangle is down. So we have superior, inferior, and medial parts. The medial part here made by the common hepatic duct. As you can see, common hepatic duct. The inferior part made by the cystic duct. And the upper part is made by the liver, inferior border. That's the triangle. And as you can see, the artery pass in it, which is the cystic artery. So the question will be how to locate the cystic artery. First, I need to locate the Calout's triangle. Medially, we have the common hepatic duct. Inferiorly, we have the cystic duct. And superiorly, we have the inferior lobe of the liver. Then the cystic artery pass within the Calout's triangle. That's it.
So hello everyone, I'm Abdul Razzak. I'm a 15th medical student, and inshallah today I'm going to be continuing this PAL session. So next I'm going to be continuing with the peritoneum. So what is the peritoneum? The peritoneum is a thin, continuous serous membrane that lines the abdominal cavity and covers most of its organs, not all the organs, only just most of them. But how does the peritoneum form? How does it develop? So during the embryological ages, we have this mesodermic cavity, tamam? And you can see that in the middle of this cavity, we have the GI organs. They are being developed. They are just growing during fetal life, tamam? While they are growing, they are pushing into this mesodermic cavity, which is going to be the peritoneum, okay? So this mesodermic cavity is developing and it's going to become the peritoneum. While it is developing, the GI organs are pushing into it like a fist into a balloon. Just try it. Like inflate a balloon, push your fist into it, and then deflate it. It's gonna take the shape of your hand, tamam? And this is what the peritoneum does. It's gonna take the shape of the GI organs and cover them completely. The peritoneum is gonna have two layers. A layer that's close and in close contact with the organs themselves, and that layer is called the visceral peritoneum. Coming from viscera. Viscera is organ. So visceral peritoneum is the layer of peritoneum touching the organ. The other layer is the parietal peritoneum, and this is the part or the layer of the peritoneum that is far away from the organs, and it is touching the abdominal pelvic wall. طيب. Now, this is the side view of the peritoneum. As you can see, it is completely covering the abdominal organs. The blue color is indicative of the visceral peritoneum, while the red lining is indicative of the parietal peritoneum. طيب, as you can see, some organs are covered completely by peritoneum. Peritoneum is covering them all around, تمام? And these organs are called intraperitoneal organs. Intraperitoneal doesn't mean the organ is inside the peritoneum. Inside the peritoneum, there's nothing. There's only some fluids, تمام? However, intraperitoneal means that the organ is covered totally by two layers of peritoneum, تمام? And these organs include the stomach, first part of the duodenum, which actually first half of it. We have the jejunum, ileum, transverse colon, sigmoid colon, liver, and spleen. On the other hand, some organs are not covered completely by peritoneum. For example, we can see these organs here, the kidneys, the suprarenal glands. They are not covered completely from all sides by peritoneum. The peritoneum is kind of only resting on them, only covering them from the anterior side. But these organs are called retroperitoneal organs. They are at the back or the peritoneum, and the peritoneum is just sitting on them. And these organs include the kidneys, ureters, suprarenal glands. Very easy to remember. They're just like three organs close to each other, and the rectum. The third part of organs are called secondary rectoperitoneal organs, and these are organs that usually, or like during developmental age, like fetus life, they used to be intraperitoneal, but then as the person grew, they became retroperitoneal. Anatomically, now, if you're looking at them now, they are retroperitoneal, just like all of these. However, embryologically, they used to be intraperitoneal. And these include the second, third, and fourth part of the duodenum, the pancreas, and the ascending and descending colon. Okay? طيب. The peritoneum itself can fold on itself and form omentums. And we have two omentas, the lesser omentum and the greater omentum. So let's start off with the lesser omentum. The lesser omentum is basically a double layer peritoneal fold. So the peritoneum came here and it folds on itself, تمام? That connects the lesser curvature of the stomach and the proximal duodenum to the liver. And Samhar already explained this. This is just basically like a connection between the liver and the lesser curvature of the stomach and the proximal duodenum. It consists of two ligaments. The first one is the hepatoduodenal ligament, which contains the portal triad, تمام? The other one is the hepatogastric ligament, which, as the name indicates, it's a ligament between the liver and the stomach, lesser curvature of the stomach. So you can see that this is the lesser sac, and this is membranous structure is the lesser sac, and it's kind of transparent, and you can see stuff behind. So the area behind the lesser sac is called, the area behind the lesser omentum is called the lesser sac, or the omental bursa. And everything in front, so the place where we're looking from, is called the greater sac. So anything or the area behind the lesser omentum is called the lesser sac. And anything in front is in the greater sac. These two sacs are connected to each other with this little tunnel here, or foramen, which is called the epiploic foramen. You can actually see that you can access the lesser sac by going through the epiploic foramen. Okay, so the greater omentum is like a curtain-like structure. However, it's a curtain that is going down, like all curtains, then going back up. Tamam? So it is a curtain that's hanging from the greater curvature of the stomach plus the duodenum, proximal duodenum. So the lesser sac comes from the lesser omentum. The lesser omentum comes from the lesser curvature, while the greater omentum comes from the greater curvature of the stomach and the proximal duodenum. So it goes down all the way. It's hanging. Then it's gonna fold back and come back up, and then attach to the anterior surface of the colon and its mesentery, specifically the transverse colon. Tamam? So you can see, if you zoom in here, that we have 1, 2, 3, 4 layers of peritoneum in this area due to the peritoneum going down, then folding on itself and coming back up. And these 4 layers are attached or fused to each other. So next is the liver. It is covered by both visceral and parietal peritoneum. So it's a intraperitoneal organ. The parietal peritoneum forms this falciform ligament that divides the liver into a right lobe and the left lobe. This is our left, but this is the right lobe of the liver, and this is the left lobe of the liver. As a continuation to this falciform ligament, you have this ligament, which is called ligamentum teres, which is a remnant of the left umbilical vein. So you might get asked, they might ask you to identify this structure, and you're going to say this is ligamentum teres, and they're going to tell you what is the embryological origin of this structure. You're going to tell them this is the remnant of the left umbilical vein. Now, we said the liver is covered by visceral and parietal peritoneum. However, there is a small area of the liver that is not covered by anything. It's not covered by peritoneum. So why does this happen? You can see this area here. This is the bare area of the liver. The bare means it's not covered by any peritoneum. Okay. You can see here that the peritoneum is folding around the liver. It is trying to reach this bare area. However, it's not able to because the diaphragm is preventing it. So this area of the liver is bare because the diaphragm is sitting on it, preventing peritoneum from reaching it. So this is very important because this bare area of the liver is more prone to injury than all the other parts of the liver. One of the main functions of peritoneum is protection of the organs. So when you have an area that doesn't have peritoneum, that area is more prone to injury. طيب. As you can see here, the peritoneum is folding and is going like trying to enclose around the liver. Then it's gonna fold back and go back again. Now this place where it folds, it thickens and it forms a ligament called the coronary ligament. So peritoneum is basically coming like this, it's folding on itself and then coming back, forming the coronary ligament. And the coronary ligament has two sides, a right side and a left side. So it's gonna continue and have two ends. The right end is called the right triangular ligament, and the left end is called the left triangular ligament. You can also see the bare area here on the cadaver and on a model. Please be familiar with those models because they might like give you like this exact same model in the questions. Tamam? The bare area is usually like lateral to the inferior vena cava. It's going to be very obvious the location of the groove of the inferior vena cava. Now let's discuss the other side of the liver, the visceral side of the liver. It's called the visceral side because it's in contact with other organs of the body. We're gonna mention it in a minute. Tamam? This side of the liver is very rough, tamam? And it has two lobes, not right and left lobe. It has caudate upper lobe and the quadrate lobe. The caudate lobe is marked by the fissure for the ligamentum venosum, okay? And on the other side, it is marked by the groove of the inferior vena cava or the inferior vena cava. It's going to be coming like this here, okay? Okay. So it's going to be, the inferior vena cava is going to be coming like this. Okay? طيب. The other lobe is the quadrate lobe, and it's formed by the fissure of ligamentum teres, okay? In addition to the gallbladder. So these are the two markings that are going to mark the sides of the quadrate lobe. Again, caudate lobe, ligamentum venosum, and inferior vena cava is going to be here. And for the quadrate lobe, it is the fissure for ligamentum teres and the gallbladder. Between the two lobes is where the portal triad, enters into the liver. So the portal triad, consisting of the portal vein, hepatic artery proper, and bile duct, they all come here and enter between those lobes. Okay, as you can see, this mush here is just consisting of the portal triad. Now, this side of the liver is called the visceral side because it's in contact with organs. And because these organs are pushing against the liver for a very long time, since you were born, they're gonna have impressions on the liver. They're gonna have their own markings on the liver, and they're gonna put their shape or their stamp on the liver. You need to know 5 impressions. The first one, or the easiest one to know, is the gastric impression. It's the impression of the stomach, and is the only one on the left side of the liver. So this is the left side of the liver. تمام. This is the left lobe of the liver from the back. And the only impression that you're going to see on this side is the impression of the stomach, the gastric impression. You might be able to see the esophageal impression, however, you're not required to know it. تمام? Just don't focus on it. Just focus on the gastric impression. Once you see they're asking you like a question about the impression on the left side of the liver, immediately say it is the gastric impression. What about the right side of the liver? This is where it gets complex. So you have a very big impression for one organ, tamam, and that is the renal impression. It's the impression of the kidney, okay? So if you see a big impression on the right side of the liver, that's the impression of the right kidney. Please be specific when writing your answers in the exam, right? This is the impression of the right kidney. Because if you just say kidney, they're just gonna assume, oh, you don't know if it's left or right, tamam? Say this is the impression of the right kidney. Above the impression of the right kidney, we're going to have the impression of the suprarenal gland, which makes sense. You have the kidney, and above of it is the suprarenal gland. So you're going to have 2 close impressions to each other. Also say this is the right suprarenal impression, okay? Now, 3 and 4 are the impression. 3 is the impression of the duodenum. As Samhar said, some part of the duodenum is covered totally by the liver. So this part of the duodenum is going to be pushing against the liver and making this impression. And as you can see, this is the gallbladder. So if you know that this is the gallbladder, and you can imagine the duodenum going around the gallbladder, right, and the pancreas, you can immediately know that this is the impression for the duodenum, okay? The last impression is for the colon, and basically the colon comes from below, it folds here, and then it continues transversely. So if you want to like memorize them in 1 minute, I would like to divide them like to 3 different parts. The first 2 are on the left side of the heart, which are the gastric impression and the esophageal impression. These are together. They are close to each other, so it makes sense. The other 2 are the right renal impression, which is the biggest one on the right side, and above of it is the suprarenal impression, and the last 2 are the duodenal impression and the colonic or the colic impression, okay? We're going to know more about the colic impression when we discuss the colon in a bit. Now, let's talk about the histology of the liver, starting off from the coverings. So this is a magnification of the side of the liver, showing the coverings of the liver. So first, it's covered by a fibrous capsule called the Glisson's capsule. Please be familiar with this name. So you can see this is the fibrous capsule here around the liver, covering it. And covering the fibrous capsule is the layer of the peritoneum that we studied, which is the visceral peritoneum, consisting of your typical mesothelial cells. Just your typical simple squamous. You can see the flat nuclei here, right? Yeah. So you can see the visceral peritoneum covering the fibrous capsule of the liver, consisting of mesothelial cells. Now let's take a look at the functional unit of the liver, which are mainly the classic lobules of the liver, which are usually hexagonal in shape. They have like 6 hexagonal borders, okay? They usually consist of a central vein, okay, and the portal triad or usual portal triad. Between them, there is a canal or sinusoids, tamam, that allows blood to flow from the portal triad to the central vein. So you're gonna have oxygenated blood from the hepatic artery proper and deoxygenated blood full of nutrients from the hepatic vein, from the portal vein, giving off blood through the sinusoids to the central vein. On the other hand, you're gonna have bile produced by the liver being sent off from the central vein to the bile duct. So you have here bidirectional flow, blood going through toward the center and bile going toward the triad. Some other cells that are included in this in those lobules are Kupffer cells and hepatocytes. And we also have endothelial cells. Okay, now let's look deeper at the central vein. Tamam? So this is a magnification of the central vein. You can see that it has a very like thin outer layer or a very thin outline. Just like any veins of the body, it has a very thin wall. And you can see all these hepatocytes scattered all around the lobules. So you see all the cells around here, or most of them, like 90% of them, are hepatocytes. Okay, you can see like millions of sheets of hepatocytes around the central venules. These hepatocytes are basically filtering blood that's coming. They're reducing some hormones and doing some metabolism. Okay. However, between those hepatocytes, you can see those white spaces, which are called sinusoids. So sinusoids function to separate sheets of hepatocytes from each other. And they allow the flow of blood again toward the central vein and bile toward the portal triad. Now, the lining of those sinusoids is not made of hepatocytes. It's made of other cells called endothelial cells and Kupffer cells. So endothelial cells are just like your any other endothelial cells of the body. Like imagine the sinusoids are like a blood vessel, tamam? But they're gonna have those endothelial cells with a flat nuclei, like they are like squamous, tamam? And you can see like a couple of them attached to each other, like any of your typical endothelial cells, tamam? So you can see them throughout here. You can see those squamous cells, right? You can see those flat cells as well. This is very, very flat and squished nucleus. So you can tell that this is an endothelial cell. The other cells lining the sinusoids are Kupffer cells, okay? And these are the macrophages of the liver. That's why they're gonna have the look of macrophages. They have a very large nuclei with a pale or lightly pink, eosinophilic or pink cytoplasm. So if you zoom in, you can see that they have these are Kupffer cells. They have a very prominent nuclei with a very vague and a very pale cytoplasm around. Now let's compare those cells that are lining the sinusoids to the hepatocytes. Hepatocytes are found on the proximity of sinusoids on the sides, not lining them, just on the side of those endothelial cells. And they are polygonal in shape, so they have the shape of like a square or a pentagon. They have large nuclei in the center, تمام? That's very, very prominent. You can easily tell this is a hepatocyte. They are like very crowded with each other, like they are like a honeycomb, تمام? You can see them, they're like lining each other, and they have a very prominent large nuclei with a pink granular cytoplasm. So if you zoom in here, okay, you can see that this is, for example, a hepatocyte with a very obvious big cytoplasm, nucleus. The cytoplasm is kind of white, tamam? It is very, very pale. At the same time, it has those pink granules all over it. So that's how you identify a hepatocyte. So on that side, we have the portal triad, okay? And the main character of the portal triad is the portal vein. It is the biggest one of them all, tamam? It has a thin wall. However, it is the biggest in size. You can see that among all these structures here, the one that has the largest radius or the biggest in size is the portal vein. And it has a very, very, very thin wall with the squamous epithelium around it, okay? The second member of the portal triad is the hepatic artery. It has squamous cells, however, it is thicker than the portal vein. You can easily tell that this hepatic artery is thicker the wall thickness is much thicker than the portal vein. However, the cells are still squamous. They are still flat, okay? You still have flat nuclei. The last part is the bile duct. So you're going to see multiple bile ducts that are eventually going to join with each other. So what you need to know is that you're going to probably see multiple bile ducts in one image. So how do you identify them? They have a simple cuboidal epithelium. If you zoom in here, you can easily tell that this is a cuboidal epithelium. The nucleus is not flat, it's not squished, and it's like standing well. Tamam? It has its own shape and its meaning and its own architecture. Okay, and you can kind of tell they are square in shape. You can also see another portal duct here, تمام, with very prominent or very like well-standing nuclei that are not squished. You can also even see another one around here, تمام. This is probably another bile duct. Yeah, if you see a cuboidal epithelium, just immediately know this is a bile duct. If you see a thin wall, this is a portal vein, and if you see a thick wall, then that's probably a hepatic artery. One last thing. These are the sinusoids, and on the sides of them we have sheets of hepatocytes. تمام? However, the hepatocytes are not in direct contact with the sinusoids themselves. Okay? There is a space between the endothelial cells and the hepatocytes, and this space is called the space of Deci. تمام? And this space is very, very important because it has two important functions. The first one is controlling secretion from hepatocytes. You don't want everything secreted from the hepatocytes to reach the sinusoids because eventually it's going to go to the body. You need to filter it before. And this is one of the functions of space of Deci. The other function is containing sterate or eto cells. These are myofibroblasts of the liver. These are usually functional when you have liver cirrhosis and you have huge fibrosis of the liver. تمام؟ طيب. Let's move on to the pancreas. طيب, it has 5 parts. The first one is the head of the pancreas, as you can see, around that, like close to the duodenum. You also have the neck, you have the body, the biggest chunk of the pancreas, and you have the tail. You also have the uncinate process, which is like a hook projection going out from the head and taking the shape of the duodenum around it. Okay. You can also see that there are some structures here going in front of the unkinase process, تمام. That's why it's not clear on this model. However, you can tell that there are some structures going between the head and the unkinase process, between the pancreas itself, like through the pancreas itself. Okay. So for the pancreas, you need to know the relations of organs around it in relationship to the different parts of the pancreas itself, starting off with the head of the pancreas. So this is the head of the pancreas, and in front of it, you're going to have the transverse colon and the root of the transverse mesocolon. What is the transverse mesocolon? It's just basically the mesentery of the transverse colon, like attaching it to the posterior abdominal wall. So basically, just to simplify it to yourself, know that in front of the head, you have the transverse colon plus its mesentery, which is called the transverse mesocolon. طيب, posteriorly, you're going to have the inferior vena cava, which is not seen on those on those figures. You also have the bile duct, which you can see here, okay, the bile duct, okay, and the right renal vein, which is also not obvious on those images. حلو. هلا, superiorly, laterally, and inferiorly, you have one organ but different parts of it. This is the head, and above of it, you're gonna have the duodenum coming like this. تمام? So superior to the head, you have the first part of the duodenum. On the lateral side, here, you're gonna have your second part of the duodenum, and inferiorly, you're gonna have your third part of the duodenum. For the unkinase process, which is the hook process like this, تمام? Okay, so it has a very important like clinical relationship to it. So anterior to it, you have the superior mesenteric artery, which originally is running behind the pancreas itself. تمام? You can see this artery here. تمام? The one I'm pointing my pointer toward. This is the superior mesenteric artery. Originally, it's running behind the pancreas, but then it runs in front of the unkinase process. تمام? Along with the superior mesenteric vein, which makes sense. Two superior mesenteric vessels running side by side. They pass behind the pancreas, then in front of the unkinase process. Usually, the mesenteric artery is on the left side of the mesenteric vein. So this is the artery. The vein is most likely going to be here on the left side, on the right side of the mesenteric artery. This picture is inverted. طيب, posterior to the unkinase process, I wish I can delete those. طيب. طيب. Posterior to the unkinase process, you can see this big artery there, okay, and it's running behind the unkinase process, and that is the abdominal aorta. So the abdominal aorta is running at the back of the pancreas, okay. it gives off the superior mesenteric artery, which continues running behind the pancreas, then at some point runs in the front of the unkinase process, and then those vessels both continue downwards. Inferior to the unkinase process, you have the third part of the duodenum. Okay, this is very simple. You can see it here. Okay. طيب, why is the superior mesenteric artery running in front of the aorta? In front of the unkinase process, very important. Because you have the aorta coming like this, tamam? It's like a artery coming like this, and you have the superior mesenteric artery as a branch of it. And between them is the unkinase process. You also have the third part of the duodenum, and you also have the the left renal vein. And all three of those organs are can potentially be squished or compressed by the superior mesenteric vein, tamam, between the superior mesenteric vein and the aorta. So you need to know these three important organs between the superior mesenteric vein and the aorta, which are the unkinase process of the pancreas, the third part of the duodenum, and the left renal vein. Next is the neck of the pancreas. Anterior to it, there is the pylorus and the pyroduodenal junction. So this is the duodenum. You would have the stomach like this, صح? In front of the neck of the pancreas, you're gonna have your pylorus and pyroduodenal junction. And then the rest of the stomach is gonna continue like this, تمام? And posteriorly, you're gonna have the beginning of the portal vein, which is made up by the joining of the superior mesenteric vein and the splenic vein. This is not only the splenic vein, this is the joining of the splenic vein plus inferior mesenteric vein. So they are gonna join before, then they're gonna join with the superior mesenteric vein behind the neck of the pancreas. Tamam? And you can also see the superior mesenteric artery, okay, running behind the neck. So the superior mesenteric artery runs behind the neck, then in front of the unkinase process. We said that. Okay, next is the body, okay, and it has a triangular shape, not exactly like this, but this is only for the sake of explanation, تمام? Like any triangle, it has a superior angle, anterior angle, and a posterior angle, and anterior and posterior surfaces, and the bottom surface. We don't care about those, تمام? We only care about superior border and anterior border, which are the angles, تمام? On the top and on the front, and surfaces on the back and the front. The superior border here, as you can see, the top of the body is, you can see this very prominent artery running on it, which is the splenic artery, tamam? So on the superior border, you have your splenic artery flowing, tamam? It is hitchhiking on the pancreas to reach the spleen, tamam? It's like guiding like a roadway for it to reach the spleen on the pancreas. Anteriorly, you have your transverse mesocolon, which makes sense because we already said that the transverse colon runs in front of the pancreas. On the anterior surface, we have the lesser sac and the stomach. So here we said that the neck has the pylorus and the pyroduodenal junction in front of it. Then the stomach is going to continue like this. And what is the area behind the stomach? We already said that the area behind the stomach, behind the lesser omentum is the lesser sac, which is the area behind the stomach, basically, okay? So this means that the body of the pancreas lies behind the stomach and the lesser sac as well, okay? Then on the posterior surface, you have many organs. You have the aorta, okay, which makes sense because we already said that aorta is running at the back. We also have the splenic vein, which you can see here, tamam, this is the splenic vein, running side by side, the splenic artery. However, it's more to the posterior side of the pancreas. That's why we said this is the posterior surface of the pancreas, of the body. We also have the inferior mesenteric vein, which is this one here, tamam, this is the inferior mesenteric vein, and we have the left kidney and its vessels. The left kidney is going to be somewhere here, so you need to imagine vessels coming in and out from the kidney and passing at the posterior surface of the body of the pancreas. The last part of the pancreas is the tail. There's nothing to know about the tail, it's just there. For the histology of the pancreas, let's take a look at a very low magnification, like a very broad view of the pancreas. You can see those septae, tamam, dividing the pancreas into lobules. And these septae, which basically are like connective tissue capsule, they have a capsule, and this capsule is extending inside, making those septae, separating the pancreas into different lobules. Now let's zoom in at the lobule. When taking a look at the exocrine pancreas, so the part of the pancreas that is responsible for digestion and whatnot in the GI tract, the main functional unit of the exocrine pancreas is called a secretory acinine. It is the part of the pancreas that's producing the pancreatic juice that's responsible for digesting food in the duodenum or in the intestine. It's basically like a circle shape, تمام? And in the middle there is a lumen, and it's surrounded by a pyramidal cells with a basoviric cytoplasm, very dark pink cytoplasm as you can see here, تمام? And a basally located nucleus. These are the differentiating factors of secretory acinine. They have a very dark pink color and a basally placed nucleus. All of these are around a lumen, okay? These acini are gonna empty their juice into bigger ducts or bigger canals called intercalated ducts. These ducts are lined by centroacinar cells. So how you usually going to identify centroacinar cells are by these light staining cells. They are very light pink cells in the middle of a very dark pink circle, تمام? So once you see those structures, very dark pink circle, and in the middle of it, a very light cell, you know these cells are the centroacinar cells, lining the intercalated ducts of the pancreas. These intercalated ducts then are going to join with each other and form bigger ducts called intralobular ducts. Intra means inside the lobules, and these are the lobules. So you're gonna have some ducts flowing inside the lobules. So they're not that big. However, they are a little bit larger than the intercalated ducts. And these intralobular ducts are lined by cuboidal epithelium. This is when the epithelium is going to be a little bit larger than your usual secretory acinine cells. تمام? You can see them here as ILDs. تمام? These are your intercalated ducts. Sorry. These are your lobular ducts, okay? And they're a little bit larger than the intercalated ducts. Hello? Now these intralobular ducts are then gonna join with each other and form larger interlobular ducts. And these interlobular ducts are basically ducts that are running between the lobules of the pancreas. So they are even larger than the intralobular ducts. These are still lined by cuboidal epithelium. However, you can easily tell that these are much larger than the intralobular ducts. تمام? So interlobular ducts are larger than intralobular ducts, and they are formed by intralobular ducts joining each other. Then all those interlobular ducts are going to drain into the main or the accessory pancreatic duct, تمام? Which are then eventually going to empty into the duodenum. So this is the exocrine part of the pancreas. A very important clinical concept here is that I actually saw it in one of the previous exams, so I thought I'm going to explain it. In cystic fibrosis, تمام, there is loss of the function of the villi in the main or accessory pancreatic ducts. تمام? So this is going to result in pancreatic enzymes staying inside the pancreas. They're not going to be able to flow into the duodenum. They are going to digest their own pancreas, damaging it and making it fail. The most important thing of this is that cystic fibrosis or damage to the pancreas in cystic fibrosis happens due to dysfunction of the exocrine pancreas, not the endocrine pancreas. If you get asked about cystic fibrosis in pancreas, just immediately say it is exocrine pancreas. As for endocrine, you have a very characteristic structure, which is the islets of Langerhans. تمام? You can easily see them. They are these white or pale staining structures scattered all around the pancreas. You can even see them at a very large magnification. This is easily a very easy islet of Langerhans to see. This is another one. This is another one. This is another one. So once you see an islet of Langerhans, this very light staining like circle or structures in the middle of a darker staining lobules, immediately know you are in the pancreas. This is the main identifying feature of the pancreas. So if you see this image or this image, or for example this image here, and they ask you, what organ is this? Immediately say, this is the pancreas. Why? You're going to tell them, I see islets of Langerhans. Tamam? This is the easiest characteristic feature that you can see on a slide that of the pancreas. Right. For the large intestines, when you're looking at the large intestine, like grossly, you can see two special characteristic features of the intestine. The first one is the haustras, or these sac-like structures. They're like bag structures all over the large intestines. Very, very characteristic and very, very different than the small intestines, which are smooth. Tamam? The other structure are tenaculi, which are continuous layer of longitudinal muscle. You can see them all over here, tamam, lining the large intestines from the beginning till the end. These begin at the rectum. This is the rectum, tamam? And you can see here that all the muscle layers are surrounding the rectum totally. However, when the large intestine start, the outer longitudinal layer of the muscle are gonna condense into these three strands of muscle, which are gonna become the tenaculi. And these are gonna continue all the way throughout the colon until they reach the root of the appendix. At the root of the appendix, they're gonna converge back and form a uniform muscular layer around the appendix. So tenaculi is basically condensed outer longitudinal muscle layer, basically three strands of them throughout the length of the colon. The inner circular layer is present all over around the colon. Tamam? But it's not different than any other organ. The only difference is that it has a condensed outer longitudinal layer into three strands. The large intestines consist of the appendix, cecum, ascending colon, transverse colon, descending colon, segment colon, and then we have the rectum on its own. So let's start off with the cecum. The cecum is the first part of the large intestines, and it is where the ileum throats its stuff there. So you can see that the ileum is a little bit protruding into the cecum, forming an ileocecal valve. Tamam? So you have this ileocecal valve preventing stuff to flow back from the cecum into the ileum. You also have extending here from the cecum is the appendix, a very, very well-known organ. Tamam? The appendix is basically appendix of the colon, tamam, extending from the cecum, and it has a mesentery. You can see that the mesentery of the ileum continues all the way and then goes and covers the appendix. Tamam? This part of the ileal mesentery covering the appendix is called the mesoappendix, which means that this appendix has a fake peritoneum, a fake mesentery. Tamam? Why is it a fake mesentery? Because usually a normal mesentery would attach the organ it's covering into the posterior abdominal wall. The mesentery of the appendix is not attaching it to the posterior abdominal wall, it is attaching it to the mesentery of the ileum. Tamam? That's why it is called a false mesentery usually, and it's called the mesoappendix. The appendix is supplied by the appendicular artery, tamam, which also runs in the mesoappendix, okay? And the most common location of the appendix is the retrocecal, which means behind the cecum. This is the most important information that you need to know about the appendix. If you only want to know one information about the appendix, know the most common location. This was even asked in the last progress test, like a couple of days ago. That's how much high yield this information is. Now moving on to the ascending colon. طيب. So the ascending colon runs from the cecum all the way up, tamam, vertically, until it reaches the liver here, and it flexes and it bends and then continues transversely. Tamam? So the colon ascends at the right side as the ascending colon. It bends at the right colic flexure. So here the colon flexes. It's gonna be going vertically, then it's gonna change direction and continue transverse. This flexure here is called the right colic or the hepatic flexure. Why the hepatic flexure? Because the liver is gonna be sitting here. Tamam? And I can see I did this very beautiful animation showing the liver sitting at the right hepatic flexure. Tamam? Now this makes sense when we said that one of the impressions of the liver was the colic impression. It is actually the impression of the right hepatic flexure of the colon. طيب. Moving on to the transverse colon. The transverse colon starts after the hepatic flexure and it ends at the next flexure, which is at the left. So it's called the left colic flexure and it's near the spleen. So it is called the left colic or the splenic flexure of the colon. After that, it descends downward in the left side and becomes the descending colon. There's something very, very special about the transverse colon is that it has a mesentery, تمام? Like the jejunum and the ileum. All the previous organs that we discussed earlier don't, like the ascending colon doesn't have a mesentery. The cecum and the appendix have a mesentery that's continuous with that of the ileum, okay? However, the transverse colon has its own mesentery, and that mesentery is called the transverse mesocolon. Now, descending colon starts after the splenic flexure, تمام, and it goes downward until it reaches the sigmoid colon. We're gonna look in a bit how to identify the sigmoid colon. But for now, descending colon, very, very simple. It begins at splenic flexure, continues and runs downwards, and it then ends at the sigmoid colon. No mesentery, nothing to know about it. The sigmoid colon, it's called sigmoid because it is curved. So once you see the colon started to become curved, you know you are in the sigmoid colon immediately. This is the curved part of the colon. You can see that most of the colon is straight, تمام, except for this part, which is the sigmoid colon. And this part of the colon, although very, very small, it has its own mesentery as well. And it's called the sigmoid mesocolon. So for now, we have 2 or 3 parts of the colon that has a mesentery. The cecum and the appendix, continuous with the mesentery of the ileum. You also have the transverse mesocolon for the transverse colon, and you have the sigmoid mesocolon for the sigmoid colon. Now, how do you identify or differentiate the small versus large intestines? We already said 2 features. The first one are house trusts, circulations, that are very exclusive to the colon, تمام? You can see them in any other organs. The second one are T. nicoli, which are the longitudinal strands of outer longitudinal muscle, تمام? The third one are epiploic appendages. These are basically those random sacs thrown all around the colon, which are pouchings of fat-filled serosa-covered structures that are attached to the wall of the colon. And the main function is protection of the colon from outside injuries, تمام? So you have all these appendages and sacs of fat that are covered by serosa thrown all around the colon. So you'd find them here, 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 all over the colon. These are the main 3 identifying features of large intestines grossly, تمام? Now let's talk histology. Starting off with the appendix, the smallest and the easiest one. It has a simple columnar epithelial cells, just like all the previous GI tract organs that we discussed and Samhar discussed. And the name of those cells are called colonocytes because they are part of the colon. طيب. What are the differentiating features of the appendix? The first one is the characteristic large lymph nodes in the submucosa. The appendix is a very lymph heavy organ. So it has all those lymph nodes that are heavy in the submucosa of the appendix. In the muscularis externa, you have the inner circular layer, like all the GI tract we discussed earlier, and you also have outer longitudinal uniform layer. Why uniform? Because in the colon, it's not going to be uniform. It's going to be condensed at some point. However, in the appendix, you have a uniform outer longitudinal layer. This is going to help you differentiate it or differentiate the appendix from the colon itself. Then you have a simple squamous epithelium forming the serosa. The appendix is very easy to know, like on histology, because you might even like be able to see the whole thing on image. So you can immediately tell, oh, this is the appendix. Like no other organ would appear like this. تمام? Now for the colon, the mucosa, again, simple columnar epithelium, colonocytes, just like all the appendix and the previous small intestine, simple columnar epithelium, تمام? And they also have crypts of Leberkin that Samhar explained in the small intestines. However, the glands here are straight. They are like you are standing. They are like standing in line. تمام? They are very, very straight, like you are having a rack of test tubes beside each other. So this is a way that it's gonna help you identify the colon on imaging. Oh, sorry, on histology. Okay. Now, what's characteristic for the mucosa? of the colon is the absence of Paneth cells. This is going to help you differentiate them from the small intestines. They are also absent or have no villi as well. These two are very important or very easy features to differentiate the small intestines from the large intestines. And then you have GALT. GALT is basically just the lymphatic nodules all around the mucosa that are responsible for protection. تمام? And in the colon, they are extensively developed. They are very, very large and very, very complex. And as you can see. So if you were asked to mention a single identifying feature of the colon, if you write GALT, they're gonna love you for it. تمام? It's very, very easy to identify. تمام? As well on histology. Okay. Going a little bit deeper, we have the submucosa, and it's just a regular connective tissue with fat cells. This is not going to help you identify anything. However, there is a special component here, which is the Meissner's plexus. It's very, very, very difficult to identify on histology. If I just memorize it, they might just get you this image and tell you how to identify what is this organ. You're going to say this is the colon. What are some differentiating features? You can say Paneth cells, noveli, GALT, or even Meissner's plexus. Now let's dig deeper into the muscularis externa. It has inner circular layer like all the GI tract discussed before, and it has an outer longitudinal layer that is, however, condensed into longitudinal bands, tinea coli. You can see here that you have a this MEI is muscularis externa, like outer or yeah, like the outer longitudinal layer. This is MEL. Okay. You can see that it's very, very, very thin. Okay. However, at some point they're gonna become very, very thick because this is the area where there is tinea coli and the outer longitudinal layer is condensed. Okay. You can even see them here on this larger image. Tamam. However, throughout the whole colon, you have a uniform inner circular layer. So inner circular layer is present all over the colon. However, the outer longitudinal layer, you might be able to hunt it at some locations, tamam? Because there are only like 3 strands of them. Another feature is another plexus between the two muscular layers, which is the mesenteric or Erbach's plexus, which again, you can't really see it on histology, but you can use it as one of the identifying features of the colon. Then serosa, you have your simple squamous epithelial cells. But moving on downwards toward the rectum and the anal canal. So the rectum is the part of the GI tract that is straight. حتى in Arabic they call it al-mustaqim because it is the straight part of the GI tract. So once you are in the straight part of the GI tract, you know you are in the rectum. It extends from the rectosigmoid junction. Basically, this is where the colon ends, straight down to the anorectal line. تمام? Anorectal line is where the rectum ends. طب how are you going to differentiate the rectum from the sigmoid from outside? You can easily tell there are no house threads in the rectum. تمام? There are no tinea coli, and there are no epiploic appendages. Okay? All these are characteristic or specialized to the colon only. You also have no mesentery of the rectum, okay? So it doesn't have anything attaching it to the posterior abdominal wall. طيب. Now, when studying the rectum, there are 3 important horizontal lines that you need to be familiar with. And each one of those lines is a marking for a change in anatomy, okay? So the anorectal line is the uppermost one of those 3 lines. And this is where the rectum ends, تمام? And this is where the upper anal canal is going to begin. Okay, so the first line, anorectal line, as the name indicates, it's between the anal canal and the rectum. So this is when the rectum is going to end and anal canal is going to start. Tamam? Then you have the dentate line. This is the line here that is not really a line. It's like a zigzag. Tamam? It separates the upper anal canal from the lower anal canal, and we're gonna discuss in a bit what does this mean. Last but not least, you have the anocutaneous line. Ano means anal canal, cutaneous means the skin. So this is the line separating the anal canal from the skin. And this is where the anal canal and the anal canal ends. Basically, anything beyond this point is skin. It's not anything different than your normal skin. Okay? طيب. Let's discuss histology of the rectum. So the rectum has the same embryonic origin as all the previous colon. It is part of the hindgut. So it makes sense that it's going to have similar histology to the GI tract. And that's totally the case. Tamam? It has simple columnar epithelium without villi like the colon. It's very identical to the colon with all the crypts and the mesenteric plexus and whatnot. However, the differentiating feature is the inner circular and outer longitudinal like uniform lining of the muscularis externa. You don't have for example, the tinaculi here, okay? You can see a uniform inner circular and the uniform outer longitudinal muscular layer covering the rectum. Tamam? And this is an image of the histology of the of the rectum. You can see all these glands, or the crypts of Langerhans, lubricant, and the muscularis mucosa layer. Okay, yeah. طيب هلا this histology is going to continue all the way until the anorectal line. What is going to happen below the anorectal line? Nothing is going to change. You are going to go anatomically into the upper anal canal. However, histologically, it's exactly the same. Again, the same reason. Because the upper anal canal between the anorectal line and the dentate line is also part of the hindgut. So it also has identical histology to the rectum. It has a simple columnar epithelium, no villi with crypts, and your normal inner circular and outer longitudinal muscle layer. طيب هلا below the dentate line is where the change in epithelium happens. So above the dentate line, you are in the upper anal canal, simple columnar epithelium. Below the dentate line, you are in the lower anal canal. And this area is going to have a stratified squamous epithelium that is non-keratinized, okay? So the way you can remember it is that this is closest to the rectum. تمام. This part of the anorectal anal canal is close to the rectum, so it's going to have similar histology to the rectum. But as you are going down, you are getting closer to the skin, so it makes sense that the histology is going to become closer to that of the skin. For the histology here, it's going to be stratified squamous, non-keratinized. The skin is keratinized, okay? So it's a little bit closer to the skin, not identical, however. And that is also when your change in embryological origin is going to happen. So before dentate line, you have the organs of the hindgut. Then below that, you're going to have the ectoderm. Okay. هلا at the dentate line, you are going to have the inner circular muscle layer thickening, تمام, forming the internal anal sphincter. And this is where we are going to discuss the sphincters. But let's just hold back for a minute and look at the junction here, تمام. So this is basically the rectum, and you can see the simple cuboidal epithelium with all the crypts and whatnot. Then at some point, it's going to be stratified squamous epithelium with very squished nuclei. تمام. To be more specific, this is the dentate line here. This is the anal rectum, the upper anal canal, and this would be the lower anal canal. Okay. You can also see them here. You can see all these, they are just cuboidal epithelium. Then at some point, you're going to see like millions of nuclei. That's why here it's more squamous epithelium. تمام? And these are the crypts of lubricants found in the rectum. Okay. Okay. So this is an image showing the thickening of the internal inner circular muscle layer of the anal canal. Now, the inner circular layer is going to be thickening, forming the internal anal sphincter. So the internal anal sphincter is basically autonomically controlled, which makes sense because we said that this is part of the GI tract. It's similar to the GI tract still. So you can't really control your GI tract. So this internal anal sphincter is autonomically controlled. It's supplied by the inferior hypogastric plexus, providing sympathetic innervation, and the pelvic splanchnic nerve, providing parasympathetic innervation. تمام? Sympathetic closing, parasympathetic opening. The other sphincter is the external anal sphincter, and this is a skeletal muscle sphincter. تمام? And it's voluntarily controlled by the pudendal nerve. تمام? You can see that the internal anal sphincter is formed by the continuation of the muscles of the rectum, while the external anal sphincter has muscles coming from outside of the GI tract, like from outside. That's why it's external. And it has three parts: deep, superficial, subcutaneous. Only know that, okay? What happened? Okay. طيب. Now the last part of the anal canal is the lower anal canal, which we said is stratified squamous epithelium. However, below the anocutaneous line, we said anocutaneous line separates the anal canal from the skin. So below that, you're gonna have identical epithelium to that of the skin, keratinized squamous epithelium. This is basically the perineal skin. Okay, this is the skin on the anus. Okay. So all of those organs that have a mesentery are intraperitoneal organs, including the appendix, cecum, transverse colon, sigmoid colon, and only the upper part of the rectum. The upper part of the rectum is covered by the mesentery of the sigmoid colon. It kind of extends and takes a small portion of the rectum with it. Tamam? All the other organs are retroperitoneal. They are only covered by peritoneum from the front, which includes the ascending colon, descending colon, and the lower rectum. So now we're going to move to blood supply. For the blood supply, we have three main aortic branches that are responsible for supplying the GI organs. The first one is the celiac trunk, tamam? It branches off the aorta at the level of T12. Please guys, know the levels, tamam? They might like ask you, what is this artery and at what level does it bifurcate or branch of the aorta? Know that level, tamam? This artery is responsible for supplying the four gut organs. Hello? Now the next branch is the superior mesenteric artery, and it branches off at the level of L1, okay? And it supplies the midgut organs. The last one is the inferior mesenteric artery, and it branches off the L3 and supplies the hindgut organs, okay? Now let's continue with the celiac trunk, okay? So the celiac trunk, like Samhar explained, has three main branches: left gastric artery, stomach artery, and common hepatic artery. Left-hand side, if you wish, okay? And it supplies the lower esophagus, stomach, duodenum, pancreas, duodenum again, because I don't know why, and gallbladder. Tamam? Okay. So now let's discuss each one of those branches on its own. Tamam? To try to make it easier. The first one and the easiest one is the left gastric artery. We said that the lesser curvature of the stomach is supplied by the left gastric and the right gastric artery. This is what Samhar explained, tamam? But this is the same left gastric artery. It's just gonna leave from the celiac trunk and go toward the lesser curvature of the stomach, giving off stomach branches, lesser curvature branches, and giving off branches to the esophagus upwards, tamam? So it's gonna go toward the lesser curvature of the stomach, supply the abdominal esophagus, and the upper part of the lesser curvatures, tamam? And it's gonna anastomose with the right gastric artery. But the second artery is the splenic artery. It is a very easy artery to identify when you see it because it's very tortuous. It's coiling like a snake, tamam? If you can see it, it is like coiling around itself. Plus, we just said that it's running on the upper side of the pancreas, tamam? You can imagine it going horizontally behind the stomach. This is where the pancreas would be sitting, right? Okay, you sit behind the stomach. It's going to be running behind the stomach all the way to the spleen. However, before reaching the spleen, it has three main branches. The first branches are the branches to the pancreas, supplying the body and the tail of the pancreas. Okay. This is very common sense because you can imagine it running on the upper wall of the pancreas and giving it branches. Okay? It's like giving it money for guiding it to the way to the spleen. Then you have the short gastric branches. These are branches going upward superiorly toward the fundus of the stomach. Okay? And last but not least, you have the left gastroepiploic, supplying the greater curvature of the stomach. So when you see gastroepiploic, you know you are talking about the greater curvature. And this gives off the left gastroepiploic, which supplies the upper part of the greater curvature. Eventually, it's going to anastomose with the other gastroepiploic artery, but we're going to talk about that in a minute. The last branch of the celiac trunk is the common hepatic artery. It is a common artery, so it gives off two main branches. The branches that it gives are still very important branches, tamam? So those two branches are the hepatic artery proper, as the name indicates, hepatic, so it supplies the liver. The other one is gastro-duodenal artery. Again, as the name indicates, supplies the stomach and the duodenum. طيب? Now let's dig deeper into the hepatic artery proper. Again, as the name indicates, it supplies the liver by two branches. Like at the end of it, when it reaches the liver, it gives off two branches. Very, very simple. Right hepatic, left hepatic. However, before it reaches to the liver and gives off those two branches, it has two side missions. Tamam? It sort of like supplies to some two other organs on the way. The first one is giving off the right gastric artery, which is kind of like would be confusing to you, because why an artery going to the right would give an artery going to the left to the stomach? It is the right gastric. So this is a very, very easy to identify it. The liver is on the right, tamam, and you have the hepatic artery proper going to the right toward the liver, giving a branch to the stomach. So that branch is going to be easily your right gastric artery, tamam? It's on the right side. Hello? And this branch is going to be supplying the lower lesser curvature, anastomosing with the left gastric artery. The other branch or the other artery it gives off is the cystic artery, which Samhar explained, supplying the gallbladder. This could be either branching from the hepatic artery proper itself or from the right hepatic artery. Hello? طيب, next, gastroduodenal artery. It's the other branch of the common hepatic artery. تمام? As the name indicates, it supplies the stomach and the duodenum. The artery to the stomach is also the right gastroepiploic artery. تمام? It goes and supplies the lower greater curvature of the stomach. So a way of identifying, of knowing like the blood supply of the stomach is dividing it into left and right circulation. The right circulation is basically the hepatic artery or the common hepatic artery, tamam? And all the arteries that end up coming from the common hepatic artery are going to be the right gastric or the right gastroepiploic. طيب, the other branch of the gastroduodenal artery is the superior pancreatico-duodenal artery. Again, as the name indicates, it supplies the pancreas, okay, and the duodenum. And it gives off anterior and superior branches. So they sort of like ride on the pancreas, tamam? Supplying it from the back and from the front. طيب, this is all for the celiac trunk. But one more last thing is the celiac angiogram. So a very good way of knowing where you are in the angiogram, you obviously know that this is the celiac trunk, tamam? It's the widest of them all, it's the biggest branch, and it's the first one that has like a color in it, tamam? To identify all the other arteries, basically, if you see this coiling artery, very, very coiling, very, very twisting, and going to the right side, okay, then this is the splenic artery. Hello? If you see this kind of MPC branch that's like it doesn't have any more branches, it's just in there at some point and it's going to right as well, this is the left gastric artery. Then the biggest branch is the common hepatic artery, and it has like a million branches out of it, tamam? Then you can eventually know that it's dividing into right hepatic artery, which is going toward the liver. If you see it going toward the liver, tamam, then this is going to be the right hepatic artery. Simple. And you might be able to see it dividing into right and left hepatic arteries. However, if you see it giving branches downward like this, then this is the gastro-duodenal artery. And you might be able to see the right gastroepiploic artery trying to go and supply the stomach from the other side. Okay? I hope this is not confusing. I hope this is very clear. طيب, this is another angiogram. This is actually one of the previous exams, and when I saw this, I thought they are very evil to bring such a question, صراحة, because it's not really very clear. However, if you just know that the splenic artery is that coiling tortuous artery going to the right, then you can eventually know that this is the splenic artery going to the right, tamam, supplying the spleen. And this would be easily the other branch that has very like million branches is the common hepatic artery, okay? And this is probably the left gastric artery, a very small branch, okay? This is like a review slide. I think there's no need to go over it again. طيب, superior mesenteric. Superior mesenteric artery is the second branch of the aorta. It goes at the level of L1. It supplies the pancreas as well, just like the celiac. It gives also blood supply to the distal half of the second part, third and fourth part of the duodenum, jejunum and ileum, appendix, cecum, ascending colon, and the 2/3 of the transverse colon. So basically all the organs of the midgut. Okay. طيب. The first ones that we are concerned about are the pancreas and the duodenum. Those are already supplied by the celiac trunk. Why are we giving them dual supply? So we said that the arteries supplying those areas is actually called the superior pancreatico-duodenal artery. So the branch coming from the superior mesenteric artery, supplying those organs is called the inferior pancreaticoduodenal artery. So why have a superior without having an inferior, right? So this is the inferior pancreaticoduodenal artery. It's the branch of the superior mesenteric artery supplying the pancreas and the distal part of the duodenum, like anything that's not supplied by the celiac artery. Tamam? Eventually, this artery also has anterior and posterior branches, and the anterior branch of it anastomoses with the anterior branch of the superior pancreaticoduodenal artery, and the posterior branch of the inferior pancreaticoduodenal artery also anastomoses with the posterior branch of the superior pancreaticoduodenal artery. So these two arteries, not only they have similar names, they also anastomose with each other through their branches, anterior and posterior branches. طيب. So we're done with blood supply for the pancreas and the duodenum. طب jejunum and ileum, very, very simple. Jejunal branches supplying the jejunum and ileal branches supplying the ileum. Okay? Straightforward. You don't have to know any more than that. طيب. All these remaining structures are supplied by one branch of the superior mesenteric artery, which is called the ileocolic artery. Ileo from ileum, colic, colon. So this is a branch that's kind of in between the ileum, last part of the small intestines, and the colon. Tamam? Which makes sense because it's like supplying all the like initial parts of the colon. طيب. Now this ileocolic artery is going to give off the ileal branches, okay, which are going to supply the distal ileum, okay. It's also going to give the appendicular artery, which is going to supply the appendix, and it's going to give off the cecal branches, which are going to supply the cecum. Anterior and posterior branches, superior and inferior branches, by the way, of the cecal artery. طيب. هلا pardon, I said no, all are supplied by one artery. No, they are supplied, like, it's going to be easier to explain them together, but not the same artery. Only cecum and appendix are the same artery, which is the ileocolic artery, giving off multiple branches supplying this area here. طيب. طيب. Ascending colon is supplied by a right colic artery because it's on the right side. So you have a right colic artery, tamam, supplying the ascending colon. The transverse colon is supplied by the middle colic artery, which is also in the middle. So it makes sense to have a middle colic artery. And between those arteries, you have continuous anastomosis, tamam, and you have a continuous artery that's running throughout the length of the whole colon. And that artery is called the marginal artery. So, for example, if they tell you, what's this part, you tell them it's transverse colon. What is the blood supply? You tell them this is the middle colic artery. But if they tell you what's an alternative supply to it, just say marginal artery. Because the marginal artery is going to compensate for any, for example, closure here, or like stenosis, for example, or any blockage in the middle colic artery. Marginal artery is just going to make up for that loss of blood. Hello? And you also have like your ascending and descending branches of the right colic artery and whatnot. تمام. بس don't worry, like you don't have to know more than that. طيب. هلا. The last artery is the inferior mesenteric artery. It supplies the hindgut, so distal 1/3, descending sigmoid rectum and the superior rectum, okay, to be specific. طيب. So it gives off the left colic artery, just like the right colic supplying ascending, middle colic supplying the transverse. The left colic artery is supplying of the distal 1/3 of the transverse colon plus the descending colon. It's also anastomosing with the middle colic artery. So all the arteries of the colon here are anastomosing with each other. They are continuous with each other, and they kind of like take over for each other. طيب. Then we have the sigmoid artery. Very simple, supplying the sigmoid colon, superior rectal artery supplying the superior rectum. But what supplies the inferior rectum? The answer is written here, okay? It is the inferior rectal artery, okay? Which is a branch of the internal pudendal artery, which is also a branch of the internal iliac artery. طيب, the inferior rectum is not supplied by the inferior mesenterics or the superior mesenteric. It's supplied by the aortic circulation. خلص. It's something different than GI. It is part of the anterior iliac artery. Lymph drainage always follow the blood supply. For the sake of time, I'm just gonna read, okay? Distal esophagus, stomach, liver, proximal duodenum, and spleen, and body of the head of the pancreas, celiac nodes, just the blood supply. Because all of these are supplied by the celiac trunk. طيب. All of these are supplied by the superior mesenteric artery. They're gonna be draining toward the superior mesenteric lymph nodes. And then you have these that are supplying into that are supplied by the inferior mesenteric artery, so they drain their lymph into inferior mesenteric lymph nodes. Okay. If you know the arterial blood supply, you're gonna know the lymph drainage like by heart. Okay. طيب هلا the superior rectal nodes drain into the inferior mesenteric. We already said that because that's where the blood supply comes. طيب what about the inferior rectal nodes? We said that the inferior rectum is supplied by the internal iliac artery. So it's also lymph nodes are gonna follow the arterial supply. The inferior rectal nodes are gonna be draining into the internal iliac nodes. تمام? What about below the dentate line? We said that below the dentate line, it's closer to skin. Like the epithelium is close to skin, the embryological region is like closer to skin. So they're gonna like drain to the lymph nodes that are draining the skin in that area, which are the superficial inguinal lymph nodes. Please be familiar with those guys. يعني, this is a very common exam question. Venous drainage. We have three main contributaries of the portal vein. The first one is the inferior mesenteric vein. We have the splenic vein and superior mesenteric vein. So we see here that superior rectal branches, sigmoid branches, left colic branches all go together and make this inferior mesenteric vein that goes all the way and joins with the spleen, or sorry, the splenic artery, tamam, where behind the body of the pancreas. Okay. Okay. And then this branch is going to go all the way and is going to combine and join with the superior mesenteric artery, which has branches on the right colon, right colon, transverse colon, ileum and jejunum and whatnot. And this is going to happen behind the neck of the pancreas. So the formation of the portal vein happens behind the neck of the pancreas, then it continues toward the liver. Okay. A very important concept is varices. Basically, when the liver is kind of fibrosed or cirrhosis, for example, there's going to be portal hypertension. The portal circulation here is going to have a higher pressure, and this is going to cause the veins at the end, which are connected to the systemic circulation, to be kind of dilated, and they're going to be bleeding. تمام? In case of esophageal varices. For esophageal varices, when you say varices in the GI, you have a vein that's coming from the portal circulation that is hypertensive, and another vein that's coming from the systemic circulation that's normal. It's trying to kind of take some pressure off it. تمام? For esophageal varices, for the portal circulation, you have the superior. This is not the rectal vein, guys. This is not the rectal vein. تمام? From the portal circulation, you have the it's the esophageal branches. Sorry, it is the left gastric vein. تمام? It's the left gastric vein. From the systemic circulation, you have the esophageal veins that are going to be draining into the esophagus vein. Okay. So portal circulation, never mind this. It is the left gastric vein. تمام? طيب. What about anorectal varices? From the portal circulation, again, this is very long. This was supposed to be from the previous. I think I confused some of them. طيب. Yeah, it's confused. Basically, this is gonna be your superior rectal vein. Anorectal varices, superior part, تمام. Portal circulation is the superior rectal vein. However, the systemic circulation, it's the middle and inferior rectal veins. Last ones are the paraumbilical varices. They're not really like a very good drawing, so just memorize them. Paraumbilical veins are part of the portal circulation, and these are the ones that are gonna be dilated. They're gonna be very obviously that they are blue around the umbilicus, تمام. And from systemic circulation, you have the superficial and inferior epigastric veins. طيب, for the anterior abdominal wall, the anterior abdominal wall has 7 layers to it, تمام. We're gonna mention them from outside to inside, from superficial to deep. The most superficial one is the skin. Then you have superficial fascia, consisting of 2 layers, a fatty layer, Camper's fascia, and a membranous layer, Scarpa's fascia. Okay, unfortunately, you have to memorize those names. تمام. Then you have the deep fascia. So after superficial fascia, it makes sense to have a deep fascia. Okay. Then you have muscles. There are 3 muscles: external oblique, internal oblique, transversus abdominis. These are the ones on the side here. تمام. The one on the middle is a different one. We're going to mention in a bit. Then we have transversalis fascia that is behind the muscles. Behind transversalis fascia, you have extraperitoneal fascia, which also makes sense because we're getting closer to the peritoneum. This is the fascia that is around the peritoneum. Then you have the parietal peritoneum. تمام. As we said, there is visceral and parietal. This is the parietal peritoneum, the layer of the peritoneum that is far away from the organs. طيب. This is how I like to memorize them صراحة. If this doesn't work for you, just know this mnemonic. Supersonic faced many troubles eating pizza. تمام. I like to associate the skin with the parietal peritoneum, the outermost with the innermost. Then you have superficial fascia, consisting of two layers. Unfortunately, you have to memorize that. Like this way, it doesn't help you memorize it, but you can like easily know it. Is equivalent to the extraperitoneal fascia. Then you have the deep fascia that is equivalent to the transversalis fascia, and in the middle you have your main character, which is the muscles. طيب, or just notice mnemonic SSSDMTEB. Okay. طيب, the muscles of the anterior abdominal wall, you have four of them. We have three on the side and one in the middle. The ones on the side are, the first one is called external oblique, and this has an inferior, okay, medial arrangement. So it's like you're putting your hands in your pockets. تمام. As you can see, this is the external oblique going this direction. Hello. The second one is internal oblique, and this is going superior medial. So it's going like this. So it's like you're making dua, okay? It's going toward the heart. Again, this is how they go. تمام. They kind of go against each other. This is how the external oblique goes, okay, toward the downwards, and this is how the, okay, like upwards, like this, okay, the internal oblique. طيب. You have transversus abdominis, which, as the name indicates, transverse, so it's totally horizontal, okay, like this, okay. And you have rectus abdominis, which is totally vertical. This is the six-pack muscle. We all know this, okay. It's in the one. This is the one in the middle. All the other ones are mainly located in the sides. طيب. هلا, normal muscles of the body, like the biceps and whatnot, have their tendons. But those muscles do not have tendons. They have aponeuroses. They are like tendons, but they are like sheets, okay, of tendons, like a big sheet of continuation of the muscle. So now we have three muscles on the side, and their aponeuroses are all going toward the middle. So those aponeuroses are gonna join and form something called an abdominal rectus sheath. تمام? They're gonna form a rectus sheath. This rectus sheath is responsible for enclosing the rectus abdominis muscle, the six-pack muscle. So aponeuroses are going to come like this. They're going to enclose this muscle in the middle. تمام? Now, normally, you would see that the aponeurosis, this silver structure here, of the external oblique muscle and the internal oblique muscle are going to go anteriorly and cover the rectus abdominis muscle from the front, while the aponeurosis of the transversus abdominis plus half of the internal oblique aponeurosis are going to go backward, and they're going to cover the rectus abdominis from behind. Hello? For now, you are going to have aponeurosis covering the rectus muscle from front and behind. However, below a certain point, below the arcuate line, okay, this is like a line here in the above the inguinal area, tamam? All the aponeuroses are going to join with each other, and they're going to only cover the rectus abdominis muscle from the front. Nothing is going to be from the back except transversalis fascia, extraperitoneal fascia, and parietal peritoneum. طيب? So they might get you this image here, tamam, and tell you, oh, is this above or below the arcuate line? So if you see aponeurosis coming back and front, this is above the arcuate line. If they are only going to the front, then this is the arcuate, below the arcuate line. This is the front, this is the back, okay? طيب. Now the aponeurosis of those muscles kind of combine at some points, and they make vertical lines, تمام? These lines are very important anatomical landmarks for us, تمام? First, they are coming from the side, and they reach the lateral wall of the rectus abdominis muscle. They form a line here called the linea semilunaris, like here, تمام? Before reaching the rectus abdominis muscle, they form a line. This is called the linea semilunaris line. طيب. Then the aponeurosis continue all the way up to midline. At midline, they form another line, تمام? And that line is called linea alba, which literally means the white line, but just I don't know why I say that, just random fact, okay? But this is basically the line that the aponeurosis form at the midline, just at the umbilicus, okay? Between the two rectus abdominis muscles. So line outside rectus abdominis is linea semilunaris. Line in the middle or the midline is called linea alba. And you can see them here on a cadaver. Linea alba in the middle, linea semilunaris on the sides. The aponeurosis of the external oblique muscle continues downwards toward the inguinal area until it reaches this area here. So it's coming like this, then it folds on itself, forming a ligament. تمام? This ligament is called the inguinal ligament. It extends between the anterior superior iliac spine from this side, iliac spine from this side to the pubic tubercle. not the pubic symphysis. There is a huge difference between the pubic tubercle and the pubic symphysis. Let's zoom in, okay? This is the anterior superior iliac spine, تمام, of the pelvis, تمام. You can actually feel it on your body, تمام. And then the ligament goes all the way to the pubic tubercle here. This is the pubic tubercle, تمام. This is the pubic symphysis. This is a very common confusing concept in the exam. They're gonna ask you, they're gonna give you A, B, C, D. Where does the inguinal ligament attach? Most students go for the pubic symphysis in the middle, which is totally wrong. You should go for the one on the side a little bit. That's the pubic tubercle. طيب. The inguinal ligament serves as the base of the inguinal canal. What's the inguinal canal? It's basically a tunnel, تمام? And like any tunnel, it has an entrance and an exit. So the entrance to the inguinal canal is the deep inguinal ring, which is the entry point through transversalis fascia. Then you have the exit at the superficial inguinal ring, which is the exit point through the external oblique aponeurosis, which makes sense. The deep one is a hole or the entry through the deeper layer of the anterior abdominal wall. تمام. Please know these layers. تمام. They might ask you, oh, what is this? You tell them, oh, deep inguinal ring. So it goes through what? Transversalis fascia, or superficial goes through external oblique aponeurosis. Now the last thing, okay, last anatomical thing is the inferior epigastric artery. So now this is the inferior epigastric arteries and the vein or vessels. تمام. Now, as you can see, there is a triangle here formed by these three structures. The first one is the lateral wall of the rectus abdominis muscle. The second one is the inguinal ligament, okay? And the third one is the inferior epigastric vessels, تمام? They form a triangle here called Hasselbalch's triangle. This triangle is is an area of weakness through which a hernia can protrude. So we said the borders medially linea semicircularis, okay, or semilunaris actually, or lateral border of rectus abdominis muscle, تمام. Superiorly inferior epigastric vessels here, and the inguinal ligament on the side. حلو. طيب. This area is very weak, or it's a weakening area that is viable for hernia protrusion. What is a hernia? A hernia, in general, means an organ is protruding. An organ is located in a cavity and it's protruding to a cavity that it shouldn't be there. For example, a case of a hiatal hernia, the stomach herniates to the chest instead of being in the abdomen. In case of inguinal hernia, you have basically small intestines protruding into the inguinal area. طيب. And if you familiarize yourself here, okay, this is the inferior epigastric arteries, تمام. This is the rectus abdominis muscle, and this is the inguinal ligament. So, in order for intestine to protrude and reach this area here, it has two options. The first one is going directly through the Hasselbalch's triangle, تمام, to reach this area, which is like the straightforward direct way, but it's kind of difficult because there is fascia in your way, تمام. But because it's weak, you can do it, okay? The other way is taking a detour and coming through the deep inguinal ring, through the inguinal canal, and then reaching the superficial inguinal ring, okay? And this is basically the two types of hernia. The first one is the direct inguinal hernia. You can see that it's going directly through the Hasselbalch's triangle. How do you know it's coming through the Hasselbalch's triangle? It's coming medial to the inferior epigastric vessels. So if you see a hernia and you want to know if it is coming inside Hasselbalch's or not, look if it is going medial or lateral to the epigastric vessels. In this case, it's going medially. So this is a direct inguinal hernia. طيب, if it is going from outside, from the deep inguinal ring and lateral to the inferior epigastric veins or vessels, this is an indirect inguinal hernia, which I kind of like to make it similar to taking a detour and taking the wrong way instead of taking the direct way through the Hasselbalch's triangle. طيب. So indirect goes through both deep and superficial inguinal rings, reaching the scrotum. Our direct hernia goes through Hasselbalch's triangle, and it could reach the superficial inguinal ring, but not necessarily. Usually, direct hernias have no way toward the scrotum. تمام? They only stay in the inguinal area. Now, all of these hernias are hernias that are herniating above the inguinal ligament. What if a hernia came like this and came below the inguinal ligament? That is going to be called a femoral hernia. It's basically a hernia protruding through the femoral ring and reaching the femoral canal. تمام? I don't know if this is really important. I saw it in like previous exams, so I should say no. I wanted to explain it. طيب. A hernia protruding below the inguinal ligament, it is called a femoral hernia, going through the femoral link into the femoral canal. This is a table showing all the types of hernias. Don't focus on this, tamam. Just ignore this, tamam. You might focus on male, older man, and woman. This might be helpful in your exam, tamam. But don't fully depend on it. Focus on its location or its orientation and regarding the inferior epigastric vessels, tamam. And if it's protruding through the deep inguinal ring or not. طيب. If it's not, then it is direct inguinal ligament, direct inguinal hernia. If it is going through the deep inguinal ring, then it is an indirect inguinal hernia. طيب. Last part, radiology. طيب, some ultrasound basics. A fluid appears anechoic. It is black. A soft tissue, like the liver, for example, is hypoechoic. It's kind of grayish in color. And bone or air are hyperechoic. They are very, very, very bright. Why so? Because these different organs have different densities and they reflect ultrasound waves at different rates. So they have different colors. طيب. So this is your typical ultrasound image that you're gonna see on an exam. Familiarize yourself with it. Like memorize it by heart. If this is like the easiest point you're gonna see in your exam, tamam. Someone called Abdul did not do that in first year and he got that question wrong. طيب. فميكي ماوس structure is basically the portal vein, تمام, with those two structures on its right and its left. طيب. The portal vein is the biggest structure. It's very, very easy to find. If you find a hollow structure, round structure with two things on the side, this is the portal vein. طيب. On its right, always on its right. تمام. On the image طبعا. On the image. تمام. On the image, not on the patient. Always to its right, you're gonna see the hepatic artery. So this is the hepatic artery, always. On its left side is the common bile duct. تمام. Once you identify portal vein, you can easily know which one is the hepatic artery, which one is the common bile duct. To its right hepatic artery, to its left common bile duct. طيب. The liver appears hypoechoic. It's kind of grayish. It's not black like air here or black blood. Here there is blood. تمام. In arteries there is blood. In bile duct there is bile. Okay, it's not totally black and it's not white because it's not air or bone. The gallbladder is anechoic. Why? Because it's filled with bile, just like the bile duct. It has no color. تمام. It is totally black. Because we said that fluid is anechoic. Right. Now they might give you this picture and tell you, oh, what is this? تمام. Then this is the inferior vena cava. تمام. How do you know it? It is just like the one below. It's always the one below. تمام. Vena cava is always the one down. The one that's close to the liver, you can easily tell which one is the liver because it's very hypoechoic and very large. تمام. The one closer to the liver is the gallbladder. The one below, always down, is the inferior vena cava. You have then Mickey Mouse. I think you guys are already familiar with those. طيب. Now this is another ultrasound that could show up in your exam, showing the hepatic veins. تمام. You have three hepatic veins. This is basically the liver. تمام. It's very hypoechoic. تمام. You have three hepatic veins. The right one, this is the right one. You have the middle one and the left one. تمام. Familiarize yourself with this image. If it's gonna show up in the exam, it's gonna be this exact same one. تمام. All of those are draining into the inferior vena cava. Okay, which is there. طيب, what is this light structure? This bright structure below or above the liver. This one is the diaphragm. Why is it very bright? It's because it has air like above it, which is the lungs. Plus, it is very dense. تمام. Because it's very dense, it's gonna appear or be similar to that of bone. So it's gonna be very, very shiny on your ultrasound. If you see this shiny structure, this is the diaphragm, and this big hypoechoic structure, this is the liver. And you can identify the three branches of the hepatic veins: right, middle, and the left. تمام. طيب. A scenario asking about a patient that came to ultrasound. Everything is normal. However, you cannot see the gallbladder on ultrasound. Why so? Because it's probably contracting. تمام. Why is it contracting? Because the patient did not come fasting. That's why we want patients coming for ultrasound of the gallbladder to come fasting so that the gallbladder is relaxing. You don't want the gallbladder to be contracting. If it's contracting, you won't be able to see it. You ask patients always to come on an empty stomach before going for an ultrasound of the gallbladder. Except if it's emergency, that's something else, okay? Because after eating, the gallbladder empties, contracts, and may not be visible on ultrasound, okay?
All right, now let's continue with the anatomy. Inshallah, that's going to be like the last part of this session. So let's talk about cross sections. So first thing I want you to know about cross sections, that if I'm standing here and you are standing on the opposite side, so this is, let's say this is our host, this is Umar Qattay. So this is gonna be his right hand, and this is gonna be his left hand. So my right hand is on his left side, and my left hand is on his right side. If I took a cross section from Umar and I looked at it, this is gonna be the right side, and this is gonna be the left side. Okay, it's opposite. So please, every single time you will read a cross section, flip your mind. It's gonna be the right on the other side, on your left side, and the left on your right side. Please keep this in mind. So like the liver is always here, while the stomach and spleen are always here. Keep this in mind. So in cross section, the image is reversed because you are standing in front of each other. So the right side is your left and the left side is on your right. How to read a C-section. So this is the C-section. First, please start from the vertebral body. So this is going to be the vertebral body. Please start from here. Okay? Always start, identify the vertebral body. Okay? In front of the vertebral body, literally in front of it, we will have the aorta. Okay? Always the aorta is literally in front of the vertebral body. Then identify the inferior vena cava, and it's on the right side, further away from the vertebral body. Okay? Please make sure you identify these structures. Then between the right inferior vena cava and the left aorta, you will have a muscular structure, which is the esophagus. Okay? So always start from the vertebral body. Then in front of it, there is the aorta on the left side. On the right side, the inferior vena cava, and in between, you will have a muscular structure, which is the esophagus. Know the vertebral body first, and then the other structures. Like, is this T1 or T2, or, you need to know the vertebral body first, then the structures. And I'll give you like tricks on how to know. There are some structures that's always on the right side of my body, and it's always on the right side of the cross section, which is the liver, inferior vena cava, and ascending colon. Okay? These structures are always on the right side. There are structures that's always on the left, such as the aorta, the stomach, the spleen, the heart, and the descending colon. So if you saw a colon on the right side, that's ascending colon. If you saw a colon on the left side, that's the descending colon. And there are some structures that's always in the middle, like here, which is the small intestine, pancreas, or transverse colon. Okay? And some part of the stomach at some point. The most important levels I want you to memorize are T12, L1, L2, L3. However, I will go through all the levels. Now, how to know which level you are in. If you see the heart, that's definitely T8, and that's the first level we have. So if the cross section has the heart, that's T8, okay? And the heart is always on the left side. Once you see a muscular structure on the left, like a big muscular structure, that's the diaphragm, okay? Because it's the only muscular structure in the whole GI tract, like fully muscular, on the left side. That's the diaphragm, and that's T9. So if you saw the heart, that's T8. If you saw a big muscular structure, that's T9, okay? There is no need to locate in T10 or T11. That's not usually asked, and there is no specific landmark. Now let's talk about from T12 till L3, L4. You will have specific structures, okay? First, we will have the kidney, okay? The kidney goes from T12 till L2. So as long as you are seeing the kidneys, which is on the both sides of the vertebral body, as long as you are seeing kidneys, that's from T12 till L2. So it's either T12, L1, L2, okay? That's the kidneys. But how to know if I'm at T12 or L1 or L2? If you saw the kidney without the hilum, so this is the kidney, and there is no lumen here, without the hilum, that's, and you saw the liver too, so kidney without hilum and the liver, that's T12, okay? Because if this is the kidney, this is the hilum, and this is the liver. If we cut like this at T12, you will see the kidney without the hilum. However, you will also see the liver. That's T12. You will also see the gallbladder appearing here. However, if you saw the kidney with the hilum, like here, if you saw the kidney with the hilum, regardless there is liver or not, that's definitely L1. Okay? Always. If you saw kidney with hilum, that's L1. If you saw the kidney without the hilum, however, there is no liver, then we are very low, that's L2. So, kidney without hilum and there is liver, that's T12. Kidney with hilum, regardless of the case, L1. Kidney without the hilum and there is no liver, then we are very low and that's L2. Then if the kidney disappeared and there is no liver and there is colon, then we are really, really low. We are even below the kidney, that's L3, L4. No kidney, no liver, and there is colon, okay? Because even here there is no kidney and no liver, but there is no colon, okay? But no kidney, no liver, and there is colon, that's pretty low, that's L3, L4, or even L5. Okay, keep this in mind. Heart, T8. Diaphragm, T9. Kidney, T12, L1, L2. Kidney without hilum and liver, T12. Kidney with the hilum, definitely L1. Kidney without the hilum and there is no liver, L2. No kidney and no liver and there is colon, that's L3, L4. Keep in mind that aorta is always present on the left and inferior vena cava is always on the right and it's further away. Liver is always on the right, spleen and stomach are always on the left. There is something called splenic flexure. I think Abdul explained it. That's at T12 and the hepatic flexure is even below that because the liver pushed it down. So it's at L1. And finally, the celiac trunk appears at the level of T12. The superior mesenteric artery appears at the level of L1 and inferior mesenteric artery appears at the level L3 and they are all originating from the aorta. So usually you will see the vertebral body with the aorta in front of it. However, at T12 you will see the aorta merged with something else. Since it's T12, that's celiac trunk. If it's L1, then that's SMA. If it's L3, then that's inferior mesenteric artery. So let's start with our first section, which is T8. How to identify this T8? First, let's start with the vertebral body. This is the vertebral body. Next to it, we have a luminal shaped tube, which is the aorta. Further away from it, we have inferior vena cava. We see a very muscular structure and with the lumen, so that's the heart. Okay, because even the heart is muscular. Diaphragm is also muscular, but it has no lumen. So this is the heart, then it's definitely T8. I wrote everything here. Now let's go to T9. We can't see the heart, but we can see a very muscular structure without lumen. Then that's definitely T9. What do we see? We see the vertebra. We see, by the way, I'm just locating, telling you how to locate, but you need to know these structures, even if I didn't say them, the numbered structures. So here we have the vertebra. In front of it, lumen structure, definitely aorta. Here, inferior vena cava. Between them, there is muscular structure. Then it's definitely esophagus, as we said. And the muscular structure on the left side, then that's the diaphragm. Here, on the right side, we always have the liver. Now, T10 and T11, we don't need really to locate. So here, the vertebra, here's the aorta, here's the inferior vena cava, and here's the esophagus in between of them. There is the liver. And here, there is a big organ. That's the spleen. And here, it's the only organ that has gas in a C-section, in a cross-section, not C-section. That's going to be the stomach. Okay? The upper part of it, then it's the fundus, stomach fundus. Here, T11, same thing. Here we have the vertebra, aorta on the left side, right next to it. Then inferior vena cava. In between, we have the esophagus. Here, the liver. Here's the spleen on the left side. And here, we are still at the fundus of the stomach. Now, T12, it's divided to two parts, upper border and lower border. You just need to know if it's T12, not necessarily upper border or lower border. So how will I know it's T12? We see the kidney. We said if we see the kidney, it's from T12 till L1 or L2. Okay? We see the kidneys, then it's definitely one of these. Do we see the hilum? No. Then it's not L1. And since we see the liver, then it's an upper part, so it's T12. So we look here, we have kidneys, we have liver, then it's definitely T12, and there is no hilum. Since there is no hilum, it's not L1, then it's definitely T12. Okay? طيب, يلا, locate some structures. We have the vertebra, we have the aorta, we have inferior vena cava. Here we have the liver. We also have a sac on the liver that appears at T12. What is it? Gallbladder. Here we have the stomach. Here we have the spleen. Easy. Now T12, lower border. Everything the same. We have a kidney without a hilum and a liver. Then it's definitely T12. We have also the gallbladder, same structures. We have the vertebra. And here, as you can see, at T12, we said the celiac trunk will appear. So as you can see, the aorta have some merging structure, like coming out of it. You can see it's not a fully closed tube. So this whole thing is the celiac trunk, since we are in T12. Another structure that we said that appears at T12 is this flexure. So once you see like a very dark brown structure, that's part of the colon. Since it's next to the spleen at T12, then that's the splenic flexure. Okay? Easy. I won't, by the way, in the middle, you will always have the pancreas, the duodenum at these levels. Again, now we have L1. How do we know it's L1? We have a kidney with the hilum. We are seeing the hilum of the kidney, this lumen in front of the kidney. Then it's definitely L1 without checking anything else. Type other structures, we have the vertebral body, we have the aorta, and we are having structures coming out of it. And since we know it's L1, then this structure is SMA, superior mesenteric artery. Also have inferior vena cava, here we have the liver, here we have the stomach, and we are having the colon. But which part of the colon? Since it's on the left side, then it's definitely the descending colon. If it's on the right side, then it's ascending colon. Same thing. L1 has upper border and lower border. Same identification. We have a hilum here, so it's definitely L1. Same thing. Vertebral body, here is the aorta, and here we have inferior vena cava. And we are seeing vessels going to the kidney, like directly going to the kidney. So these are renal vessels, most likely the renal vein. As you can see here, it's renal vein. In the middle, you will have pancreas, duodenum, jejunum, whatever. Usually, if it's here, more to the right side, that's pancreas, more to the left side, then that's duodenum, jejunum, and these things. Here we have a very darkish brownish structure, then that's definitely colon. Since it's on the right side, then that's ascending colon. Here it's on the left side, then that's descending colon. Here we still have the stomach going on. Here we have L2. How do we know it's L2? We have a kidney without the hilum. So kidney, either T12, L1, or L2. It's without the hilum, so it's not L1. And there is no liver, and there is colon, so we are below. Then it's L2. That's how to identify. Same thing, vertebral body, aorta, inferior vena cava, here ascending colon, here descending colon, here transverse colon. Pancreas, duodenum, jejunum, whatever. Now we have L3. How to identify it's L3? We don't have a kidney, as you can see. We don't have a liver, and we have colon. So if you didn't see a kidney nor a liver and a colon, then we are way below the level of the kidney, which is till L2. So we are either L3, L4, L5. Not necessarily you will identify, but the more you go down between L3, L4, L5, the less colon you will have. So here we have a lot of colon, 4 segments, as you can see. So this ascending, this descending, this transverse. That's L3. Now, same thing. There is no kidney, no liver, and there is colon, then it's definitely either L3, L4, L5. We have fewer colon. Here ascending, here descending only. So that's L4. So you don't really need to locate. Finally, we don't have a kidney, we don't have a liver, and we have few colons, very few. Then that's the last part, which is L5. Vertebral body, aorta, inferior vena cava, ascending colon, descending colon. Easy. Now, these are from the anatomy from Dr. Shahid lab. However, there are some other cross-sections Dr. Ataf loved to ask, and they are not in the picture, so please bear with me. Here, same thing. We have a vertebra, we have the aorta, we have inferior vena cava, and in between we have esophagus, okay? Which part is this? It's probably either T10 or T11. You don't need to locate, but there is no kidney, so it's not at T12 at least. Okay, it's way above that. Now I want you to bear, focus here. Here we have the spleen, here we have the liver, and so on. Here is the stomach, and it's asking what's this structure. This structure is a fusion between the stomach and the esophagus here. Okay, so what's gonna be? Gastro-esophageal junction. Okay, so that's one. Focus, because that's very common in the exam. This is the esophagus, this is the stomach. In between, what we will have, gastro-esophageal junction. What's this? Inferior vena cava, easy. Now here, we have kidneys, okay? And we have the liver, and there is no hilum. So we are probably at T12, or like, most likely T12, okay? Definitely T12. Anyway, let's look at the structures. You don't need to name all of these because usually it's not asked. But I want you to name this. This is the gallbladder. And this. We have a colon next to the liver. What's going to be? Hepatic flexure. So hepatic flexure either appear at T12 or L1. Depends on the person themselves. Okay, so if you saw colon next to spleen, that's splenic flexure at T12. If you saw colon next to the liver, that's hepatic flexure. We got this in the exam, I remember. Now that's for the cross section. Now we have sagittal section. If you divide me like this and look, okay, it's gonna be يعني بالطول. Okay? Wait, I think, yeah. Let's start with the mid sagittal. Let's go to the person themselves and cut them in half. And look, this is easy. This is very easy because يعني you don't even need to memorize. Just cut me in half and يعني try to think what's gonna this be if you cut me in half. This is gonna be the liver. What's here? What's next to the liver? This is gonna be stomach. What's this lumen going all the way? That's esophagus. See, what's this colon? What's this colon? What's this under the stomach? It's gonna be a pancreas. Like if you cut someone in half, just think what is gonna be in half? Liver, stomach, pancreas. See, some stuff are like on the real end, such as the spleen or like the kidneys. So in the middle, just think what in this human being will be in the middle. You will have the liver, you will have the stomach, you will have the pancreas, you will have the duodenum, esophagus. See, easy. Oh, okay. Now we cut him at the left side. So here is the liver on the right side. Here is the stomach and spleen and colon on the left side. Some parts of the liver may reach here because the liver is very big. So only a few parts of the liver will appear. Here's the whole stomach. Here we will have the kidney. Here we will have colon. Here we have small intestine. See, يعني, just memorize them and they are easy to locate. Finally, we have on the right side. Right side, we will have liver, we will have colon, we will have kidney, we will have like part of the pancreas, part of the duodenum. So we'll have a big part of the liver, big part of the kidney, part of the small intestine, and so on. Yani they will probably ask you about this. By the way, they don't ask usually about sagittal section. Anyway, that's concluded for our session. خلاص, please fill this form for the feedback. Give us your honest feedback about the session so we can like improve it inshallah later on. All right, thank you. Inshallah, see you in next PAL sessions.